patients. So now this made the generalized recommendation not to offer upfront cytoreductive nephrectomy in intermediate and poor risk patients, and rather reserve it for favorable risk patients. The retrospective studies afterwards showed better outcomes with cytoreductive nephrectomy plus systemic therapy. However, we have to keep in mind that these patients were selected and there is an inherent selection bias, and most patients that benefited had actually favorable risk factor or risk profile. We have the paper published in 2021 with one risk factor. Overall survival with cytoreductive nephrectomy and sunitinib was longer than sunitinib alone. However, it did not reach statistical significance. Another study in 2014 showed that cytoreductive nephrectomy with anti-angiogenic factors had better overall survival. Again, these are retrospective studies with some inherent selection bias in them. Another study showed that the overall survival was better with cytoreductive nephrectomy and targeted therapy. Most of these studies, again, are retrospective and with post-hoc analysis. Again, we don't have the solid data or a trial for these patients. To summarize, currently, the current role for cytoreductive nephrectomy, it can be offered upfront with metastatic RCC in patients with good functional status and favorable risk profile. Otherwise, systemic therapy first is indicated, followed by reassessment of cytoreductive nephrectomy if the response is appropriate. Currently, we have these ongoing trials. We have the Nordic Sun that is examining deferred cytoreductive nephrectomy with immune checkpoint inhibitors, and we don't have results yet, so we'll see. Also, we have an ongoing trial, CytoShrink, examining the role of radiation therapy with Epi-Nivo. And we have the SWOG probe trial with immune checkpoint inhibitors with or without cytoreductive nephrectomy. So we'll have a better answer about who are the appropriate patients to receive cytoreductive nephrectomy and what is the best timing for them. Metastatectomy, on the other hand, can be done at the time of nephrectomy, or if patients develop mets later, or in patients with persistent disease despite systemic therapy. Usually, metastatectomy is offered prior to systemic therapy only in oligometastatic disease, 1 to 3 mets, where the full resection of metastases is warranted. Here we see a paper examining 270 patients with recurrent renal cell carcinoma. 51% underwent complete metastatectomy, and the rest had either partial resection or no resection. The patients with complete metastatectomy had the highest 5-year overall survival at 44% compared to 13 and 11. In this paper, the strongest predictors for prolonged survival were disease-free interval from nephrectomy to developing mets, single site versus multiple sites. Lung mets had better outcomes, and patients with good functional status had better outcomes. Thank you. Again, based on in patients who have metastatectomy done, so they are M1 with no evidence of disease after resection, 1 year of pembro is indicated based on the subset of patients examined in the Keynote 564. However, in the study, bone and brain mets were not included, and they were treated mostly with radiation rather than surgery. What about residual disease after systemic therapy? Again, data supports metastatectomy as well, only or favorably if complete metastatectomy is achievable. Again, another study with low number of patients. However, it shows that complete metastatectomy after systemic therapy improved survival. However, short-term survival, 2-year study. What about the location of the metastases? The favorable site for metastases is lung, because complete resection of lung metastases improved survival compared to other sites. Here, this paper examines the lung-only metastases, and the survival was improved. 5-year survival was 73% compared to 19%. Again, this paper was published in 2011, so we don't have updated data on with the use of the newer agents, TKIs and immunotherapy agents. Bone mets usually currently are treated with radiation. However, the best results were seen with solitary bone lesion that is resected or multiple bone-only mets that are resected. Brain mets, unfortunately, carry poor prognosis and with high morbidity as well. However, favorable outcomes were seen in patients treated with targeted therapy with time to diagnosis less than 12 months. And the less favorable were seen in patients with early recurrence and more than 4 sites of brain mets. Liver mets are difficult to manage. However, in patients treated with curative intent, survival more than 24 months was achieved. However, liver resection usually carries also high risk of morbidity. So patient selection is quite important. What about local recurrence? Limited data shows that resection of local recurrence may actually prolong survival. Best outcomes were seen in patients with prolonged time from nephrectomy to local recurrence and patients with smaller volume residual disease. Palliative nephrectomy can be offered in patients who are symptomatic or bleeding. Bleeding patients can also be managed with angioembolization. Colic can be managed with stents. Paraneoplastic syndromes tend to improve with systemic therapy and targeted therapy on a symptom-based management for hypercalcemia, fever, and anemia, and weight loss, and so forth. Thank you very much.
Thank you, Dr. Badr, for your outstanding presentation. And now I think the time for Q&A session. I would like to ask our speaker to join me, and Dr. Sharm.
I am with you.
So for who's joining online, now the time of question. If you have any question, just feel free to post your questions. Maybe I'm gonna ask the first question regarding now during the era of adjuvant pembrolizumab, in case of recurrence, during the adjuvant or after the adjuvant completion for the adjuvant pembro, do you consider re-challenge the patient with IO in the future as a first line? Maybe we'll start with Dr. Faisal.
Thank you, Dr. Adil. Actually, the direct answer, there is no standard. But we are looking actually after the adjuvant immunotherapy and the time of recurrence. Actually, the expertise recommendation, if the patient develop recurrence after 1 year of immunotherapy, it's an option actually to give immuno-TKI or immunotherapy-based treatment. And even some expertise, if the patient recur after 6 months of the stopping of immunotherapy, still you can use. But if the patient less than 6 months, the standard of care actually to give TKI, not rather than giving immunotherapy-based treatment.
Dr. Abdullah.
Thank you so much. I will not add anything to what's clearly mentioned by Dr. Faisal. The most important thing actually is the time of recurrence, and they said roughly less than 6 months or more than 6 months. If it's more than 6 months, you can re-challenge. Especially we have, some evidence about phase 2 clinical trial. However, if the patient less than 6 months, definitely the best option is to go with TKI.
So what about those patients who has like small growing lesion, for example, during the adjuvant pembro? Would you think adding TKI during the adjuvant pembro?
So it's almost now clearly that if it's only small, we usually observe the patient. I will not jump very quickly to start, TKI. I will observe the patient closely. If it's only one site or one or two site, I may consider SBRT for this therapy. I will not consider it failure, except if it's clear progressions. At that time, definitely there is no role of immunotherapy. I'll go with TKI.
Agree with Dr. Abdullah. Actually, if you consider this patient for resection or SBRT, you will continue adjuvant as NID, which is no evidence of the disease. And this is actually the best population that benefit from adjuvant immuno. So directed metastatectomy or SBRT, continue Bembro.
Thank you. Maybe our next question to Dr. Badr regarding the cytoreductive surgery in those patients who has intermediate or poor risk. Does the site of disease or the burden of disease play a role, and who's going to be the best candidate for upfront cytoreductive surgery in those patients?
Yes, thank you. So generally speaking, in patients who have a favorable risk profile, upfront cytoreductive nephrectomy is extrapolated or thought of as having a better outcome. However, in patients with poor or intermediate risk, we usually prefer to have systemic therapy. I'm not aware of any specific trials regarding who would benefit from what is the maximum benefit in what patients, but patients who respond nicely to systemic therapy usually tend to do better after cytoreductive nephrectomy. Yeah.
Actually, I have a question regarding those patients who achieve complete remission, assuming that the patient has one metastasis and with systemic therapy achieve complete remission. Do you consider curative intent with nephrectomy?
Yes, thank you for all the speakers for these excellent presentations. My question to Dr. Faisal and also maybe Dr. Asham, you can comment on that. We have some patients, they have a deep response, like some of them achieving a complete response with IO TKI. What are you doing with those patients? Are you going to continue with treatment indefinitely, or you are doing like de-escalation sometimes, and which medication you stop?
Thank you, Dr. Amin. There is no standard, but now with the studies of the Bembro, actually they kept the Bembro for 2 years. So again, you can use Bembro up to 2 years. If the patient complete response, you have the option of to continue TKI or not. For me, actually, if the patient have complete response and I can stop TKI and observation. But if the patient achieving good partial response, still there is a disease, I tend to continue TKI alone. TKI without Bembro 2 years, then continue TKI. Complete response, there is an option to stop both of them after 2 years.
Any comment, Dr. Abdullah?
Yes, I agree totally with Dr. Faisal. I mean, we need to differentiate, Dr. Amin, between two important, either deep response or complete response. If patient have complete response, I usually stop after 2 years. I go 2 years, then I stop totally the treatment. Now, if still deep response and still there is a good residual disease, I go directly with what's written in the clinical trial and what's recommended in the clinical trial with 2 years of pembrolizumab, and I keep the patient a very small dose of TKI. So, for example, if I start with the lymphatinib, I keep the patient in 4 and sometimes 8 milligrams, and in Cabo, I keep the patient 20 milligrams. And I have a good number of patients that they are doing remarkably well in this very small dose after induction of 2 years of therapy.
Yeah, just to comment on surgery after complete response. We do, I mean, maybe also Dr. Mohammed Al-Khamis can give us his opinion, but we always see some focus when the kidney is examined pathologically that there is still residual disease in the kidney despite resolution of metastases. So I think even if the patient receives or gets full response systemically, I think cytoreductive nephrectomy is always warranted in these patients. Yeah, Dr. Mohammed agrees as well.
Excellent. Go ahead.
Assalamu alaikum. Dr. Abdullah, this is Safwan. I have a question for you. So if you have a patient who basically progressed on first line Pembro lenvatinib, second line cabozantinib, and this is a very common scenario that we see in our daily basis. So what would be your third choice? So knowing that belzutifan is not always available, and the window that we have is actually quite short. So what would be your choice?
So what I do exactly in my practice, if I don't have belzutifan, so the best option is to go with the belzutifan if it's available. And if it's not available, I will go with everolimus. And if the patient progresses in everolimus, I go with another TKI. However, the result is not very optimistic and is not the best that we would like to see. However, this is the evidence that we have. I mean, I think the patient, if it progresses in TKI and immunotherapy, the thing that we need to try something else, and we go usually with mTOR inhibitor or with hypoxia-induced factor inhibitors. So I usually go with everolimus in subsequent line of therapy if the belzutifan is not available, which is most of the times.
Thank you. Oh, we have a question here from Dr. Mohammed. What's your expert opinion about immunotherapy-related nephritis, especially for those patients who has underwent nephrectomy, and if it's happened with your patient before, is the patient improved, and would you consider resuming the immunotherapy or not? Dr. Faisal?
Regarding the toxicity of immunotherapy, actually in those with the grade 3 and grade 4 toxicity, definitely permanently you have to stop the immunotherapy. For those with the grade 1 and grade 2 and treated and resolved, if you have other options, better to change to other option. But again, you have the option to restart immunotherapy if it is a grade 1 and 2 and resolved after steroid treatment. But I will be cautious for those patients because they have a single kidney. So maybe considered first TKI, then if you have no options, you can restart if it is a grade 1, a grade 2, and resolved after treatment.
Dr. Abdullah, you have a comment?
So the most important thing actually, and this very common scenario, that nephritis related to immunotherapy is very difficult to, diagnose. And sometimes we need to go to take a biopsy. And even the biopsy, it will tell you this is nephritis, and we don't know what's exactly what we are dealing with. So most of the time, I agree with Dr. Faisal. If the patient have grade 3 and grade 4, I usually try to avoid avoid immunotherapy. And if it's grade 1 or 2, I'll be very cautious because we have only single kidney. And most of the time, I have only one patient that I was suspecting, and we cannot confirm it actually. And I stopped immunotherapy because, as clearly mentioned by Dr. Faisal, he has only single kidney, and we don't like to bring the patient for curing the patient from the disease and make him on dialysis for 4 years. So I keep the patient on TKI and I hold immunotherapy even for, grade 1 and grade. Thank you.
Excellent. I have a question regarding your experience with belzutifan, especially with the specific side effect, which is the silent hypoxemia. Have you seen those patients, and how would you deal with those side effects?
So Yasser, I have almost four patients within belzutifan, and me and Dr. Bassam, and we did not face actually any problem with hypoxia. And the majority actually, they have some sort of drop in their hemoglobin and with anemia. So and none of them actually require or to receive any blood transfusions. However, we do not see any hypoxia. All the time I monitor my patient and I ask them to measure their oxygen in home, and we did not find this, although it's a very well-known side effect, but not find it. And matter of fact, we don't know what we should do if we have a patient with hypoxia. We don't know.
Actually, I have one patient. I only have one patient on belzutifan, and he has significant hypoxemia. So, during follow-up, I tried to reduce his dose, and the hypoxemia improved. Do you have any comment, Dr. Faisal?
Actually, it's limited number and newly approved. So there is no experience still with this medication. But as you said, you can stop you can reduce the dose of the patient resolve, but actually still we don't have experience with such side effect.
Excellent. Do we have any further questions?
Faisal, you mentioned about the biomarkers and said we don't have any biomarker which can help us. There was a big talk about KIM-1 in the ESMO, and they were quite hopeful that this will become a standard of care. Do you think it has any role in the management of renal cell carcinoma, or is it now like any other biomarker in the past, just gone from the conferences into the books and that's it gone?
Actually, it's a matter of time. We'll see. We'll see the data after the data. Until now, no. It's not. We are not using as a biomarker clinical-wise, but we'll see the data.
Because the data was very strong, and it's very much predictive of response and prognosis. So I think it will come.
Yeah, but what about the survival? Survival benefit in selecting the cases based on the KIM.
Yeah, so we don't know yet, but this is it's mainly the predictive marker, and it's it does give you prediction and also for response. The conference I've attended, the author was very enthusiastic about it, and we were thinking it will come. Since not coming, but it was presented in ESMO a few months ago. So most probably it might be soon.
Hope that.
Thank you.
Any questions? We still have some time for questions. So I have a question regarding the other subtypes of RCC, Dr. Faisal, Dr. Abdullah. What's your approach in terms of sequencing the treatment in those patients?
Again, for those with the non-clear, they are dividing the European, they are dividing the papillary and non-papillary. For the papillary, actually, you have the options of the, we have phase 2 trial ala Bembro, Lenvatinib. We have the option of giving Cabo. This is the options for the papillary and non-papillary. Again, you can use single agent Cabo, you can use the Bembro, Lenvatinib, you can use even TKI, and rarely you use in subtype طبعا for the collecting duct. We know that we are using like the chemotherapy, like the urothelial. Again, in some cases we are using Lenva everolimus, but the commonly used regimen actually Cabozantinib or Bembro Lenvatinib.
Thank you, Dr. Faisal. Dr. Abdullah, any comment?
So usually I use the TKI plus immunotherapy in those category of patients, except if it's medullary or collecting duct, I usually go with the chemotherapy. So do we have clear evidence? We do have very small evidence from here and there, and we have phase 2 clinical trial. And I will go with the TKI plus immunotherapy in the first line setting. And except, as I said, collecting duct and medullary, they never respond to the TKI or immunotherapy, and I usually go with the chemotherapy.
Excellent. I have a question for Dr. Badr regarding those patients who has a VHL disease. Is there any contraindication or any thinking about doing the surgery or starting the systemic treatment for those patients? I mean, for local disease.
I mean, I'm not aware of any trials yet, but I think a lot of them will come up now, especially with the recent approvals for belzutifan. But if the disease is surgically resectable locally, I think surgery is indicated. If it is significant, if it's locally advanced, maybe a trial of systemic therapy is warranted, especially if the morbidity of surgery is quite high. But I'm not aware of any data in this regard. But I personally, if the disease is resectable, I would go for surgery for upfront.
Thank you, Dr. Badr. Dr. Muhammad, go ahead.
Thank you, Dr. Adel, and the whole panel as well as speaker. So my question is for hereditary leiomyomatosis, which is used to be papillary type 2, what would be your option of treatment, Dr. Faisal, Adel?
Again, if it is a surgical disease, I think
No, metastatic.
Metastatic disease.
Yeah.
Again, for the papillary, you know, there's a lot of phase 2 trial to use cabo or pembrolizumab. So the options based on the European recommendation, either cabo single or pembrolizumab.
Would you attempt, there was a phase 2 study of erlotinib plus bevacizumab for this subgroup of patients, and it's actually one of the preferred options. So would you consider it, or you would stick to IO TKI with pembrolizumab as it have included all kind of histologies?
Yeah. Actually, I have a good experience with this combination for a long time, pembrolizumab, even the lymphatinib single agent before the era of immunotherapy. So this is my preferred regimen, actually. And most of my patients, even non-clear, they are responding to this regimen. So this is my preference. But again, it's an option to use the other regimen.
Thank you.
So, Mohammed, if you allow me, Dr. Yasser, erlotinib plus bevacizumab, it was studied in phase 2 clinical trial, and I totally agree with those who has hereditary lymphomatosis. I think this is the best option for the patient. However, erlotinib is not anymore available now in the market, and it's almost it's not available anywhere. I mean, erlotinib, gefitinib, all these old generation TKI is not available anymore. And definitely, if you have patients with hereditary lymphomatosis, metastatic disease, I think the best option is to go with erlotinib plus bevacizumab as one of the options that's very well studied in phase 2 clinical trial. We need to keep in our minds a very rare disease, and usually they don't respond to any sort of therapy. So I think this is an indication clearly. This is the only indication for this type of disease, erlotinib plus bevacizumab.
Excellent. We have a question maybe to Dr. Badr in the context of cytoreductive nephrectomy and metastectomy for metastatic RCC. How do you approach surgical planning when the contralateral kidney has a renal cyst? Does the presence of simple or complex cyst influence the eligibility or the timing of surgery?
You mean if there is a suspicious contralateral lesion in the other kidney?
From online, so I think what I understood.
Yeah, well, it depends on the contralateral lesion. If it is small enough that warrants surveillance, we'd probably do that. However, if we're going for complete resection of any residual disease, I would do a staged procedure. I would do a cytoreductive nephrectomy and probably a partial on the other side. But I think also surveillance, if it is small, can be done as well.
Thank you, Dr. Badr. We have a question here from the online attendee about any program for early detection and screening, concentrating on target group. Faisal?
Screening for the small renal masses. Actually, it's not standard, maybe, Doctor. There is no standard, such standard to screen patient or general population for renal masses.
Dr. Abdullah, you have a comment?
I mean, only those for VHL patient or those who has congenital disease like Buerger syndromes or hereditary lymphomatosis, and those patients, they have their own screening program, including of them ultrasound of kidney. Dr.
Badr, you have any comment?
Yeah, we get this question a lot, especially from the family of patients. Should we be screened? Should we, if a family member is diagnosed with RCC? I mean, I usually follow the guidelines regarding the age and if it is non-clear cell histology. If the patient is young or with non-clear cell histology, I usually refer them to genetics and offer them screening for the family members. I don't know if you have any different experience or approach to these patients who are asking, or especially family members who are asking for screening.
Thank you, Dr. Badr. We have a question here. Maybe this is going to be the last question. What's the treatment option after failure of the first-line chemo in medullary RCC?
Again, there is no standard. But if you follow the guidelines for the urothelial cancer, maybe I will use taxane-based I don't know if Dr. Amin, Dr. Abdullah, Dr. Faisal aware about data for enfortumab. You mean the after failure of yes. So yeah, enfortumab Bimbro. But for me, taxane-based treatment.
Dr. Abdullah, do you have any comment?
Chemotherapy. I usually go with gemcitabine, cisplatin in the first line and keep taxane in the second line therapy. Hardly we have patients who receive second line therapy with medullary. They died usually within 6 months, even with the systemic chemotherapy.
One who is 5 line, and I didn't know what to do. I just gave him he was very aggressive, gemcitabine. So, and sunitinib, everything to him. He received 5 lines, and he was alive for 5 years. Alhamdulillah.
It's because he is with a great physician, Dr. Faisal.
Yeah, try urothelial guidelines. Maybe
Yes.
enfortumab. Try even Bimbro enfortumab.
Yeah, I think we should, yes.
All right, I think we reached the end of our first session. I would like to thank our speaker for their excellent discussion and lectures. I would like also to thank our attendee for their participation in the questions. So we will have a break now, then we'll come back with the second session.
Thank you so much. يعطيكم العافية جميعا.
We had
Assalamu alaikum wa rahmatullahi wa barakatuh. We would like to thank you all for joining today and for your questions and participation. Please be informed that today's agenda and today's event log is available in our app. Make sure to download our app so you stay informed. Also, please have a look at the chat box. We just sent now the attendee registration link, the first one for today. Please make sure to fill it. And we'll be sharing another 2 links throughout the day. Thank you very much. السلام عليكم ورحمة الله وبركاته. شكرا على مشاركتكم وإثراءكم للنقاش. نرجو لكم وقت علمي ممتع مفيد، ونود إعلامكم بأن رابط التسجيل تمت مشاركته في صندوق الدردشة chat box. الرجاء العمل على ملء البيانات الخاصة بكم والمتابعة البرنامج، حيث سيتم مشاركة رابط جمع الحضور لمرتين أخرتين خلال اليوم. شكرا لكم، ونراكم بعد 20 دقيقة بعد break. We'll see you in 20 minutes after the break. Thank you very much. Stay tuned. السلام عليكم، أسعد الله أوقاتكم بالخير. أود لفت نظركم بأن رابط الحضور تمت مشاركته في الشات، الرجاء تعبئته قبل بدء السيشن القادمة، وسنقوم بمشاركة رابطين آخرين خلال اليوم، نرجو منكم تعبئتهم. Assalamu alaikum. We'd like to inform you that the attendee collecting link has been shared in the chat box for today, and we'll be sharing it for 2 more times throughout the day. Please make sure to fill it, and please enjoy your educational journey today. Also, would like to inform you that all information about the targeted audience, CMEs, agenda for the 2 days are available on our app. Please make sure to download our app, which is a small app that you can have it in your screen, home screen and mobile, where we notify you about the upcoming CMEs and events. Thank you very much for your interaction and your questions throughout the day. They were really excellent questions and we hope to see more. Thank you very much. We'll be starting in 2 minutes. Thank you very much. We shared the registration link in the chat box again now, and also we shared the link to register in our next week event. Feel free to register to earn your CMEs. قمنا بمشاركة رابط تحضير الحضور للمرة الأولى في الشات بوكس، وقمنا أيضا بمشاركة رابط المؤتمر القادم الأسبوع القادم حتى يتسنى لكم التسجيل والحصول على الساعات المعتمدة إذا كنتم من الفئة المستهدفة. شكرا جزيلا لكم.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. First of all, I would like to congratulate Dr. Ashwag and Dr. Mohammed Al-Karni. We would like to thank them for inviting me to moderate this session along with Dr. Ali Al-Tijani. Today we're going to start session 2, the bladder cancer session. We have first Dr. Mohammed Al-Khamis. Dr. Mohammed Al-Khamis is an associate professor of urology, and he's a consultant uro-oncologist and robotic surgery at National Guard Health Affairs in Riyadh. He's going to be talking to us on the treatment of BCG-resistant bladder cancer. Dr. Mohammed Khamis, تفضل, the floor is yours.
بسم الله السلام عليكم. جزاكم الله بالخير جميعا وجمعتكم مباركة. It's frightening to be among smart people. As surgeons, we don't understand a lot of medicine. When we come and stand with you oncologists, it's a very weird feeling. I'll do my best to talk about the assigned topic. Alhamdulillah, it's an easy topic and difficult topic at the same time. A decade ago, we never talked about this patient population. We never talked about BCG-responsive bladder cancer, but in the last decade, there have been a lot of trials looking into new medications other than BCG and chemotherapy to manage this population. Let me just thank Dr. Ashwag and the rest of the organizing committee for this nice event. I'll do my best to stick to the time. And please, moderators, let me know if I'm running late. Right. So BCG first was introduced in the 1976, and it gained its FDA approval in 1990. It's a very nice medication for those patients with high-risk non-muscle invasive bladder cancer, and it became the standard of care. BCG is a powerful medication. 80% of patients who get started on intravesical installation BCG, either by induction or induction with maintenance, will have very good response. 45% of patients will have recurrence within 5 years, and 15% will have progression within 5 years. So all the medications that we look at right now, they have to achieve two things. It has to decrease the recurrence, and it has to prevent the progression. Now, why this topic is gaining popularity? Why is it important nowadays? Because BCG, it does work. However, it reaches to a stage until it doesn't work, and we need an alternative. Most patients initially respond, but recurrence and progression still happen, even if they had a very good initial response, and even if the response continued until 5 years. Once unresponsive, time becomes a biological ticking bomb. So, and based on the evidence, once the recurrence comes back, you have limited time to intervene and do something. The issue with all the trials and research that was done on BCG-responsive bladder cancer is the heterogeneity in definition. Different entities and bodies define BCG-responsive, BCG-refractory, and BCG recurrent bladder cancer differently. However, we rely on the standardized definition by FDA. A patient will be labeled BCG-responsive if he does have or she has a carcinoma in situ with or without papillary tumor within 12 months of starting adequate BCG, or a high-grade TA or T1 within 6 months after adequate BCG. Now, adequate BCG is also important because, again, this is a source of heterogeneity in all trials. That means at least 5 out of 6 doses that are given weekly in the induction phase. And if the maintenance is given, at least 2 out of 3. Now, why more BCG is less? We used in the past, before having alternative medications, to always go and re-challenge patients with an induction BCG again and again and again and start them on maintenance. So further BCG with true defined patients with unresponsive, BCG-responsive bladder cancer is not recommended because it will unlikely to work. And after the second induction, each additional course induction course, the risk of progression to muscle invasive disease is about 7%. Now, we can see here, based on the definition, because the European Urology and American Urology and ASCO, they define a BCG refractory failure before and after 8 months differently. However, it's very clear that the lower curve here in BCG refractory disease, they have much worse cancer-free survival. Now, the risk of progression also to muscle invasive disease is higher with this patient population. So in a delay in managing those patients, you are endangering them to having incurable disease. Now, it's easy to talk about radical cystectomy for me as a surgeon, and I'm not here to convince you, but it is the standard of care for any patient who has BCG responsive disease. And who are those patients who should be offered? Patients who have very early relapse or recurrence, especially with multifocal carcinoma in situ, in high-grade T1 disease that is multifocal with lymphovascular inversion and possible variant histology. Cystectomy is always the standard of care. If the resection is incomplete due to technical issues, irresectable tumor, patient is not compliant or he will not stick to the surveillance schedule, again, radical cystectomy is the best treatment option. Cystectomy in this case should not be considered as a failure. In BCG unresponsive disease, cystectomy is often the cure. All the guidelines, European Urology, American Urology, NCCN guidelines advocate for radical cystectomy as the first aid option and only option, honestly, for patients who are fit to undergo radical cystectomy. But we are not here today to convince you about radical cystectomy. I'm here to talk about what had changed. So is bladder preservation a reasonable thing to do? Because we always want to preserve the bladder as much as we can. But is it reasonable? Is it safe to do? Patients who are not fit for radical cystectomy, do you have anything else to offer them with a very good response rate? And if the disease is confined to a small area where we can do bladder preservation, can we do that? And when we do surveillance, we should always put in mind an exit rule, an exit strategy, because preservation here is with rules. It's not a hope for cure. Now, in the last decade, there had been a lot of talks about intravesical therapy, new medications, and new modalities, and we'll shed the light on some of them. It had not changed the guidelines yet, and there is a lot of research going on and as a phase 2 and phase 3 trials. And I think in the next 3 or 5 years, we'll have a paradigm shift in the management of such patient population. We'll talk about intravesical chemotherapy with or without device-assisted intensification, the new era of intravesical gene therapy, like adstiladrin and intravesical oncolytic viruses, intravesical immune augmentation, immune with BCG, and intravesical sustained delivery systems like Intar 200. So chemotherapy had been used for a very long time for patients who have high risk BCG unresponsive disease. Gemcitabine has been utilized initially. The complete response at 3 months is good. However, it's not a durable effect. The 2 years recurrence, the cure rate goes down to 20%. If we add docetaxel to that, that had been studied as well. There had been multiple RCTs about it. The 2-year recurrence-free survival is not impressive, 46%. If it's only for high-grade disease, it reaches up to 52%. A good chunk of patients, about 20%, will have cystectomy, and 4% of the patients progress to muscle-invasive bladder cancer. Now, there are big trials like the Hyman trial that was done in the UK that looked into delivery systems for chemotherapy, like mitomycin. So they studied BCG versus radiofrequency-induced thermochemotherapy effect, and they found it to be beneficial with patients who did not have carcinoma in situ in their pathology. The median follow-up was good. However, that did not translate in good results for carcinoma in situ. Electromotive drug administration, where the electrical current is utilized to increase the delivery of intravesical chemotherapy, had been studied. However, the studies were small and the results were heterogeneous. The recurrence-free survival was not impressive, and it was never approved by the FDA or AMA for the use. So I'll pause after each part and I'll talk what does the trials are telling us right now. So intravesical chemotherapy has good early activity in BCG-unresponsive disease. However, it lacks the durability, especially when we have carcinoma in situ. The outcomes decline usually with repeated salvage chemotherapy, and it does not replace cystectomy in a fit, high-risk non-muscle invasive disease. It's good to talk a little bit about our beloved Pembro, because it's been utilized now, not as a monotherapy by itself alone, but it's used with other intravesical agents to enhance the effect of the intravesical drug. So in cohort A of Keynote 057, Pembro as a monotherapy was given for carcinoma in situ and papillary disease, either TA or T1 high grade, and the complete response at 3 months was around 41%. The 12 months complete response was even better, around 50%, and the FDA in 2020 approved it as medication that can be used for patients who are not fit or not willing to undergo cystectomy. In cohort B of Keynote, the effect was not seen on non-carcinoma in situ. Disease-free survival was about 43% at 12 months and drops down as time goes by. And unfortunately, it never received the approval by FDA for non-muscle invasive disease. The issues of Pembro as a monotherapy is it's a systemic immunotherapy, and it does have a level of toxicity, even if grade 3 and 4 adverse events are not high. But we do have a local disease, and we're exposing patients to systemic side effects. The evidence is strong when we have carcinoma in situ. In the absence of CIS, it does not work well. And again, in high biology, it's better to go for cystectomy. As Tiladrin is an intravesical non-replicating adenovirus gene therapy. This is there had been multiple trials that talked about them, and it does have a good response. So there is a lag in the slide, sorry. So there had been some trials that looked into this medication, and it does show a good response at 3 months, especially in high-grade disease as compared to carcinoma in situ, which is opposite to the rest of the drugs. It reaches up to 73% at 3 months, and in a way it is sustainable. So at 6 months, it's about 62%, 58%, and 43% at 12 months. Now, we can see here that we have carcinoma in situ with papillary disease, the proportion of patients who does have a response does drop with time. However, it is better when you have a papillary disease around without carcinoma in situ. So the high-grade disease, as we said, has better response by 3 months. By 36 months, the high-grade recurrence-free rate was about 23%. Of the 35 patients who initially had good response at 3 months, 31% of them remained disease-free by 36 months. So the initial response does mount to a good response in the future. Now we can see here that cystectomy-free survival is about 63% in high-grade disease. It's less with carcinoma in situ, and the overall survival reaches up to 91% in papillary disease, and almost the same for carcinoma in situ. Now, 42% of the patients underwent cystectomy, so almost half of the population in this research had to undergo cystectomy eventually, and 15 who achieved complete response at 3 months, and 29 who did not. So in December 2022, it was utilized for patients who have carcinoma in situ with or without papillary tumor. So what do we see from this kind of medication? This was the first FDA-approved intravesical gene therapy for BCG-unresponsive bladder cancer. It demonstrated that durable bladder preservation and long-term data showed it is sustained benefit in subset of patients, especially the papillary disease. A significant proportion of our patients had cystectomy. So for me, when I interpret this result, cystectomy is still the standard of care. However, if the patient is unfit, or like in our population, they're resistant for a cystectomy, that might be a good medication to start. Cretostimogene or CG0070 is probably one of the most exciting drugs that we are relying on in the next decade to show benefit. It's an oncolytic adenovirus designed to replicate the bladder cancer cell to alter the retinoblastoma pathway. There had been a couple of phase 2 trials like BOND-2 that looked into it as a monotherapy, and the complete response in that trial at 3 months at any time was about 65%, at 6 months 43%, and 12 months 28%. It was not impressive. However, this led to another phase 2 trial, which is CORE 001 trial that incorporated systemic Bimbro with it, and the complete response at any time was around 57% and 83% at 12 months. So in December 2023, it got the FDA approval as a fast track, and the FDA had been very busy in the last decade looking into fast track approval for intravesical therapy, trying to look for a medication. So when we look at the literature for all intravesical therapy, we see that the entry point is always a good complete response at 3 months, and they will always be granted the FDA approval. However, most of the time that does not get translated in very good durable effect with time. And this led to the phase 3 trial, which is the BOND 003 trial that looked into this medication as a monotherapy, and patients were allowed to challenge with another reinduction, and the overall complete response was about 75%, which was impressive. And what we see in this medication, unlike the other intravesical therapies, is that the results are durable with time. So we see here it's about 64% at 12 months, and after a year, it's also impressive at 56%. Now, at 12 months, when we look into our patient population, 97% were free of disease progression to muscle-invasive bladder cancer. And this is a very important point to look at, because we know that high-risk carcinoma in situ and high-risk papillary T1 disease, they have a nasty biology that might progress into muscle-invasive bladder cancer. And a medication that decreased that percentage is a good medication. And cystectomy rates were much lower, like 90% had no cystectomy at 12 months. And the results were sustained, and those who did not had an early recurrence after being re-challenged with another reinduction had a complete response with time. Now, the side effects are very important, and we can see here this is a medication that has probably no grade 3 and above adverse events, which is similar to almost to BCG. All the adverse events were mild and self-limited and usually resolved with time. So it's a medication that ticks all the boxes. As we speak right now, we don't know, but it is shows good efficacy signals. It has a high response rate and excellent short-term protection from disease progression and from cystectomy. The durability data are maturing as we speak, and the results are highly promising. And as I said, this is probably one of the most exciting emerging intravesical medication. This might be a future pillar for bladder preservation protocol. However, it is not a reason to delay cystectomy or offer the patient this medication as a standard of care as opposed to cystectomy in high risk and fit patients. Now, augmentation of immunotherapy is a new thing that the research started to think about. Is what if you go immune with BCG? Would this help? So interleukin-15 QUELT 3032 was done as compared to BCG alone, and the results were not bad, and this was published in the New England Journal of Medicine. We can see here that in 12 months, the durability of the response was about 96%, and in 3 years is about 60%. So this is not bad, and this gave us a new understanding on adding immune augmentation as on top of BCG is a good modality. So cytotoxic salvage chemotherapy that we used to give in the past is not the only pathway. We can always augment with immunotherapy. However, this works in mostly carcinoma, predominant high-risk bladder cancer. and the FDA approval validates this concept of immune augmentation. The long-term data will let us know in the future if this will stay our goal. Now, what had been done in TAR 200 as a medication, or as we call it, the pretzel, is a new delivery medication for a already medication that we have. So gemcitabine had been done as a sustained release device, which is here. It's inserted by cystoscopy, and this defied the old techniques that we used to do. We have expensive medications that I'm almost done, that we put in the bladder for a couple of hours, and these expensive medications are voided sometimes beforehand. However, when we have this sustained release mechanism of a non-medication, would that change the outcome? And to be honest, the Sunrise phase 2 trial outcomes are quite promising. It shows about 83% of response as when in the monotherapy arm. I think in ESMO this year, 2026, they will present their final results, and it will be interesting to see, because that can be tested on many medications. So for the sake of time, I'll skip into the algorithm. Many research, many articles, many new modalities, how to look into them. So the field now is moving from cytotoxic salvage, immune, gene, viral, and augmentation. You have 3 questions that you need to answer, more importantly than the name of the drug or the chemistry or the biology of the drug. What is the durability of this medication? The protection from progression, what is the percentage of that? And the cystectomy timing, was it beneficial or not? And for BCG unresponsive disease at 3 months, as I said, the entry ticket is the complete response at 3 months, and at 12 months, the complete response, disease-free survival, and progression-free survival are very important things that we need to answer. So as an algorithm for you, once you have a patient, you have to confirm initially, did he receive the adequate BCG? Did he have a high-grade recurrence? Is it confirmed or just a low-grade recurrence? Did he have carcinoma in situ alone or carcinoma with papillary disease? And always re-TRBT if possible. More pathology is better for us to make a decision, and always risk stratify. If you find carcinoma in situ, heavy disease, early relapse, T1 with high grade, multifocality, lymphovascular invasion, or variant histology, cystectomy is always there to stay. Don't delay, because delay of cystectomy usually leads to bad outcomes. If radical cystectomy is not feasible or the patient refuses, then choose based on the current evidence we have. So in carcinoma in situ and papillary, maybe immune augmentation is a good option. Adstiladrin is a good option as well. You can always get included in compassionate use of TAR 200 or other medications if the patient really is not fit for a cystectomy. Chemo is always there to stay in salvage cases as a bridge until you have another option. Always put an exit rule in writing between you and the patient. Don't hope. Time is an essence. It's a ticking bomb. Biology of non-muscle invasive disease is very bad. So know when to do cystectomy if what you're providing or proposing is not working. And put in mind that bladder preservation in these cases is reasonable, but should not cause the patient the cure of the standard of care. Thank you very much.
Thank you, Dr. Mohammed Al-Khamis, for this excellent review for the BCG-resistant bladder cancer. So we'll keep the question to the end. We will move to the next presentation, which will be by Dr. Mubarak Al-Mansour. He's a well-known oncologist. He's a chairman of oncology department and at Princess Noura Oncology Center at King Abdulaziz Medical City National Guard in Jeddah. Dr. Mubarak is going to speak about the role of neoadjuvant in urothelial bladder cancer. Please, Dr. Mansour.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم. Thank you for the kind invitation. Do you hear me very well, Dr. Amin, and the rest of
Yeah,
the people?
yes, yes.
And do you see the slides?
Yes, we are seeing the slides. Yes, go ahead.
Thank you. So I would like to thank the organizing committee, Dr. Ashwag, Dr. Muhammad, Dr. Kanaan, and Dr. Nafisa, as well as the arranging this event. And my apology, I'm in another event at the same time here in Jeddah. I would love to, inshallah, attend such conferences. So the outline is to the adjuvant into the bladder cancer, and primarily we are talking about the muscle invasive. So we'll go through the introduction and background about the bladder and the subtypes as well as the stages, just to
Mubarak,
see
if you
what
can raise
entities we
your
are talking.
voice, if you can raise it, please.
How is it now? Is it clear? Do you hear me now, Dr. Amin?
Yes, go ahead.
So so I'll be talking about the muscle invasive bladder cancer primarily, and the new data, especially in the neoadjuvant setting, pre-radical cystectomy for both cisplatin fit, cisplatin unfit, and as well as just one or two slides on the neoadjuvant in the bladder sparing strategy. As you can see in the slide, the global can in 2022, the incidence of the bladder cancer exceeding 600,000 cases, and it ranks the ninth among the other cancers. The mortality more than 220,000 cases, about 3% of all the cancer deaths, and it ranked 13th among the other causes of cancer death. So we are talking here about one of the top 10 incidence cancers worldwide. If you take the Saudi Arabia, the new cancers according to the Global Can in 2022, so same about 3.3% from the new annual cases, it ranked the ninth, and the death is about 2.7 from all the cancer death, not from the 922, because you can see about one third of those patients died of the bladder cancer. However, 2.7 from all the cancer deaths from the other solids and hematological malignancies. A majority of all the bladder cancer, as you can see, are transitional cell carcinoma. However, we have another subtypes. So 90% of the bladder cancer from the urothelial in the bladder, and about 10% into the upper urothelial. The other subtypes, about 9% squam, adenocarcinoma, small cell carcinoma. So primarily, our talk today will be a muscle invasive and talking about the transitional cell carcinoma. This is just to remind the subtype or the classification of the non-muscle invasive, which highlighted and stated very clearly by Dr. Muhammad in the previous talk. I will be talking about the muscle invasive bladder cancer, which approximately 20% of all the new cases. And despite the radical cystectomy, that's very important that about 50% will develop a metastasis. So here we are talking about half of the patient with just only a local therapy, they might develop a metastatic disease. The purpose of the local therapy is to control the disease. The preoperative or the neoadjuvant is to eradicate the dissemination of the micro metastasis, and cisplatin therapy was the only therapy demonstrating survival benefit into the preoperative setting. So if you take the 5-year survival for the localized bladder cancer, is still low, and we are talking about a 5-year relative survival by all the stages. But if you take those high-risk patients with a residual cancer after, for example, a radical cystectomy, T2 or more, the 5-year survival rate is only at 60%. So this is area of an unmet need, and this is the area where we have primarily a shared between the urology, medical oncology, radiation oncology, and a clear MDT is required to discuss such cases. The new adjuvant setting, this is a meta-analysis. The practice was initially the adjuvant post the radical cystectomy. However, this is a meta-analysis taking in account the single agent platinum as well as the platinum-based combination. And you can see a single agent platinum-based new adjuvant did not improve the overall survival. However, if you see the combined cisplatinum-based, primarily with the gemcitabine, significantly improved the overall survival and reduced the risk of death by about 13%. So this was the a practice is any patient undergoing a radical cystectomy, the new adjuvant should be a cisplatinum-based treatment, which improved the overall survival. The dose adjusted, the dose dense MVAC versus just the standard gem says another meta-analysis, but you can see here that most of the weight in that meta-analysis came from the Visper study, which compared the 6 cycles dose dense MVAC compared to the gemcitabine 4 cycles. They included also certain retrospectives in addition to another prospective, which is the SWAG. The dose dense MVAC increases the overall survival, but did not increase the pathological complete response. As you know, the SWAG compared a 4 dose dense MVAC versus 4 GCP or the GC, sorry, cisplatinum gem, compared to a 6 cycles dose dense MVAC into the Visper compared to the 4 cycles of the. So as you know, from the 6 cycles dose dense MVAC, there was a delay for the radical cystectomy, a high toxicity, and also a high rate of discontinuation. So probably a majority of our practice is based into the standard gem cis as a new adjuvant setting, and that cisplatinum, not a carboplatin. We know the data from the metastatic setting that the carboplatinum is inferior to the cisplatinum. So what is the rationale of combining the platinum-based with the immunotherapy? We've seen a data from the cisplatinum plus the immunotherapy, for example, the atezo. It showed that cisplatinum compared to the carbo, it started to modulate the immune system and the transcriptional program, which make the tumor cells more sensitive to a T cell killing process compared to the carboplatinum. So if you combine immunotherapy, it should be a cisplatinum-based combination compared to the carbo in the new adjuvant setting. What did we learn from the initial studies, either a phase 2 or phase 1, a small sample using immunotherapy combined with the platinum-based therapy? Here is the table for, you can see the sample size between a 43 or 39, and the maximum here is a 57 patients in that study. The pathological response ranging from a 30 to a 40 or to a 50%. So adding immunotherapy to the cisplatinum improved the pathological complete response. Data also from a single agent immunotherapy, primarily from the PURE study and the APACUS, also, or combining the double immunotherapy EP-Nivo or the dorvatinib, achieved a complete pathological response between 30 to 40%. So that evidence of combining the chemotherapy with the immunotherapy led to more phase 3 clinical studies, because what we learned from that combination is that immunotherapy alone can be over a way to cure a cisplatinum ineligible, and we have a data later on. Even if we consider the enfortumab as those drug antibody conjugates, the immunotherapy improved the pathological response 30 to 40%, with the combination up to 50%, and that combination is additive rather than a more of the synergetic. So based on that evidence and the rationale, a lot of the clinical trials, phase 3, tested the combination, primarily the cis-gem in the new adjuvant setting in the muscle invasive, either with the Pimpro into the MK, the Gemcis plus Pimpro for cycles, followed by radical cystectomy, and then 13 cycles of Pimpro, the Niagara study, which will present in the next few slides, and also the Pimpro EV. We know the Pimpro EV was one of the area tested as the also cisplatinum fit patient, not just only the unfit. And the energizers, which combining the cis-gem nivo and the lundrostat mesylate, which is a selective and irreversible one of the IDO1 inhibitors. We have the data presented from the Niagara study that was in Barcelona in the ESMO in 2024. To remind, the study population were the adult cisplatinum eligible muscle invasive bladder cancer, T2, T24, in 0 or 1, M0, urothelial, or those with a divergent also differentiation or histological subtypes. 500 in each arm, compared the Dorva added to the Gem-Cis for 4 cycles, followed by radical cystectomy, and then 8 cycles of the Dorva, compared to the standard arm, which is the Gem-Cis as new adjuvant and no adjuvant setting in that data. So the dual primary endpoint was the event-free survival and the pathological complete response. As you see, the cisplatinum dose was given as a 70 milligram induced with the creatinine clearance 60 and above, and a split dose at 35 in a day 1 and 8 for those with the creatinine clearance 40 to 60. 60% at T2 or more. The baseline characteristics were very well balanced between the two arms. The formal analysis, which was in January 22, it showed the pathological response rate about 33.8 compared to 25. However, there was a 59 evaluable samples were omitted initially from the formal analysis, and later the reanalysis, including those 59, it showed that the complete pathological response at 37 compared to 27, so about 10% absolute differences into the pathological response by adding the Dorva to the cis-gem compared to the cis-gem alone. The primary endpoint, which was also the event-free survival, a 32% reduction in the risk of progression with the Dorva compared to the standard arm after a median follow-up about 42 months. You can see also at 24 months about 7 or 8% differences into the event-free survival at 2 years. The overall survival at 25% risk reduction and the risk of death in the Dorva compared to the standard arm, the Gem-Cis. The absolute differences also in the range of the about a 7 absolute differences, 7% between the two arms. Did the Dorva led to more discontinuation into the new adjuvant? You can see 14%, 15%. So there was no additive delay or interruption or dose reduction by adding the immunotherapy to the cis-gem. There was no more delay into the surgery, so it was very well tolerated, slightly higher grade 3 and 4 into the Durva arm, but did not affect the primary outcome, primarily or undergoing the radical cystectomy. So based on a phase 3 study data from the Niagara, the new adjuvant GEMSIS plus the Durva showed a significantly increased overall survival and was recommended as a new standard of care. So nowadays, for any patient who is fit for the cis-GEM, going for a radical cystectomy, the standard of arm is the Niagara if the Durva is available. What about the cis and fit patient? Also, 3 ongoing studies, one already published, which is the Keynote 905. There are also the NIVO is tested also with the BMPG as the new adjuvant setting, and the Volga study is the Durva plus the TRIM plus the AV, 3 cycles, followed by the cystectomy, and then another 1 cycles of the dual immunotherapy, and then a single agent immuno for cycle 2 to 9 for those patients. We have the data also published from the Keynote or presented into the ESMO in Berlin last year in 2025. So to again go over the study, they included the muscle invasive bladder cancer, T2 to T4A. And that they included not just only the cisplatinum ineligible, but there was another also a cohort of patients who declined the cisplatinum. And this was one of the, would say, drawbacks of that study, including such cohort, because the definition of cisplatinum is very ineligible, very clear. However, declining cisplatinum maybe there is no clear criteria why did they decline the cisplatinum. However, in that study, there was no adjuvant into the standard arm because cisplatinum unfit, so they proceeded directly to the radical cystectomy and then observation compared to the experimental arm, which is the EV plus Pimpro for 3 cycles, and then followed by a 6 cycles EV and total and 14 cycles of Pimpro. So a total of 17 of Pimpro, new adjuvant and adjuvant, and 9 cycles of the EV3 as the new adjuvant and 6 as adjuvant setting. The primary endpoint was the event-free survival. So 170 patients in each arm. The baseline characteristics were matched. However, you see in majority of the ECOG performance stats were 0 and 1, only 12% 2. So majority of the cisplatinum definition primarily was not based into the ECOG status. The ineligible 83, however, they included the eligible about 16% into the EV Pimbro and 20% into the standard arm. T3 4 78. So majority of the presentation were T3 and 4 in that. The event study or the event-free survival, which is the primary endpoint, a 60% reduction in the risk of the event-free survival compared to just radical cystectomy in that cisplatinum unfit or declining cohort of patients. The median survival was not reached into the EV Pimpro compared to a 15 into the control arm. You can see the subgroup analysis also, including those who are declining, also even the line crossed, the one, but this is primarily maybe explained by the sample size rather than the effect. However, it was clearly in those with cisplatinum ineligible, they benefited, and majority of the subgroup analysis from that intervention with the EV Pimpro in unfit patient. The overall survival about 50%, also reduction in the risk. However, this is still maybe a need to have a mature also maybe presentation in the later on about the overall survival and the event free survival. The subgroup analysis also showed benefited in the overall survival among all the subgroups. The pathological complete response 7 in those who received the EV Pembro and the new adjuvant compared to about 8.6 in those directly underwent the radical cystectomy. The usual EV Pembro side effects you would expect to see in terms of the pruritus, alopecia, and fatigue, as well as the elevation. However, you can see majority of them as grade 1 and 2. So based on that, the Keynote 905 is the first phase 3 study to show improved efficacy outcome with a preoperative therapy relative to the surgery for a patient with muscle invasive who are ineligible or for the cisplatin-based chemotherapy. So added to the radical cystectomy may represent a standard of care. And I think at least we are practicing this based on this data for those patients who are not fit for the cisplatin. 2 slides about the bladder preservation, because there are also a patient who prefers to go under the tri-modality, which is the maximum TURBT neoadjuvant as well as the concurrent chemorad rather than the radical cystectomy. However, this is one of the just preliminary data and first analysis in one of the Hellenic GU cancer trial, where they included a patient also with the treatment naive muscle invasive T2 to T4 going for a concurrent chemorad, and they added the Nivo 14 days prior to the concurrent chemorad, and then 480 milligram every 4 weeks for 6 cycles. And the primary analysis showed there was a differences also by adding the Nivo to the concurrent chemorad. Adjuvant chemotherapy given in the group, which I think can be considered. The overall survival improved, and the failure-free survival also improved by giving the Nivo. They are waiting for the Keynote 992 as well as the SWAG study, chemoradiation, placebo versus the chemoradiation and Pembro for 1 year, and chemoradiation versus the Atizo. So those are ongoing studies in the addition of immunotherapy to the chemo, concurrent chemo rad into the TMT modality. This is also another table showing a small sample clinical trials by adding the checkpoint inhibitors before the bladder preservation, either with a new adjuvant or without new adjuvant therapy. So in summary, the preoperative systemic therapy is a standard of care. Dorva, Jim says, significantly improved the event-free survival, pathological complete response, and overall survival. If no new adjuvant checkpoint is possible, then the new adjuvant, Jim says, or the dose dense MVAC for those in a patient. The adjuvant, I did not talk about it today, but it should be considered if no new adjuvant given, or for a certain high risk muscle invasive bladder cancer post the new adjuvant setting in those patients who received cisplatin preoperative. The EV Pembro for cisplatin ineligible muscle patient significantly improved the event-free survival and overall survival. So one of the option, the new adjuvant preoperative systemic therapy, depending into the plan of the definitive. So radical cystectomy is clear for a cis fit or unfit. However, for the bladder preserving strategy, chemoradiotherapy is still the local treatment. However, the new adjuvant chemotherapy with a cis-gem or the dose dense MVAC, if a patient fit for chemo, but so far there is no adjuvant immune checkpoint inhibitors, or the immunotherapy can be considered as the standard of care. Thank you.
Thank you so much, Dr. Mubarak, for this excellent presentation. So Dr. Mubarak will leave us for some commitment. So we will take like a couple of questions, and then after that we will continue on in our session. So maybe I will start, Dr. Mubarak, with the question about this, the Niagara trial,
Sure.
which actually use immunotherapy with the chemo. Actually, the design of this trial did not differentiate between the adjuvant and neoadjuvant immunotherapy. So they did not address this issue. Do we need both phases, especially in those patients with complete pathological response? So do you have any comment on that?
Well, I think this is very important, Dr. Amin. So we have the new adjuvant phase, we have the adjuvant. Maybe the new adjuvant, that's why they have the two primary endpoints, which is the pathological complete response, as well as maybe the disease progression or the progression-free survival or the event-free survival as the primary. That will be difficult, for example, for those going for the tri-modality, because you cannot assess exactly the complete pathological response, but that absolute differences into the pathological complete response at least support the new adjuvant part. However, the adjuvant setting, maybe we've seen a more data now about the circulating DNA and the importance in those patients. I think that will maybe justify or at least estimate exactly the weight of the adjuvant setting in the future. But from the study design, you cannot split and say it's primarily from the new adjuvant or from the adjuvant part.
Okay, thank you. Any more questions for Dr. Mubarak?
Yeah, I have maybe a last question for you, Dr. Mubarak. How about if someone gets a pathological complete response? So, for example, you have someone with muscle invasive, you repeat the scans, and it's basically showing no disease. And we tend to see those patients who refuse surgery at some point. Do you think watch and wait strategy is coming to bladder cancer in those who receive complete pathological response?
We know, to Safwan, that the primary treatment is either radical cystectomy or the concurrent chemo. That's the local treatment. And this is what I tell my patients is what we are giving either as a new adjuvant or adjuvant is additive and not the primary treatment. So the primary treatment is the radical cystectomy. And I discussed that with them clearly that even the improvement into the symptoms, or if we did get anything that should not eliminate the primary treatment. This is, I think we have no clear evidence in a such patient. But if they achieve the complete pathological response that based on a radical cystectomy, Dr. Safwan?
No, based, for example, for another cystoscopy and
for another cystoscopy. Yeah, I mean, this is very, very tough situation, but we have to discuss that again. But at least if they are not going to proceed for a radical cystectomy, we have to think about a concurrent chemo in a such patient, even they received a new adjuvant-based immunotherapy. But this is a scenario that we face in the practice once in a while.
Yeah, definitely. I agree with you that radical cystectomy is the treatment of choice.
I have a question maybe for Dr. Mubarak and Dr. Khamis. For those patients who has a systemic disease, is there any role for curative intent treatment or surgery, especially if they have like complete response systemically?
So from our part as a medical oncologist, if the patient does have a metastatic disease or locally advanced, there is no point of doing a primary treatment for the primary tumor if the goal is to improve the survival. However, if this is to improve the symptoms or to palliate, this is we can consider sometimes a radiotherapy as a palliative doses. Surgery, very, very unusual situation, but will be based into the presentation. However, it's not the practice, and we are not discussing a patient for the primary radical cystectomy in the metastatic disease for overall or curative intent, except for a certain patients if the symptomatic needed and discussed into the MDT.
I agree with Dr. Mubarak. It makes sense, like we do cytoreductive nephrectomy in the setting of metastatic RCC, but there is nothing to support this in the evidence for cystectomy. The only time to go ahead and do it if the patient is having very bad symptoms, like persistent hematuria with recurrent admissions for transfusion, if they do have a lot of slough tissue and they keep recoming with infection where you cannot continue your immunotherapy. And in the past, I'll have to say this, in the past we used to tend and refuse to do cystectomies, and as Dr. Mubarak said, push them away towards radiation therapy. Radiation will take care of the local disease, but however, if it's not for bleeding, if it's for infection, for T4 disease invading the bowel, radiation will probably make things worse, where you cannot continue systemic therapy, where surgery would be a better option in that case.
There is one question online from the online audience. I think, if I understand it well, is there any difference in complete pathological response in patients who receive those dense MVAC versus GIMSIS? Dr. Mubarak?
We've seen from the meta-analysis that I presented in the initial slides, there was no differences into the complete pathological response. However, there was overall survival differences. I think majority of the medical oncologists are preferring the standard GIM-CIS because of the tolerance, because of the also giving it as outpatient setting. Less toxicity would not delay the primary treatment, which is the radical cystectomy. However, from the meta-analysis, there was no differences between the dose dense MVAC compared to the GIMSIS.
Perfect. Thank you so much, Dr. Mubarak Mansour, for your input. And now we'll move on to the third talk. So it's my pleasure to present Dr. Mohammed Saifan. Dr. Mohammed Saifan is a consultant medical oncologist. He's the head of the oncology section at the Security Forces Hospital Program. He's also a clinical assistant professor at Princess Noura bint Abdurrahman University in Riyadh. He will be talking about how to define the first-line therapy in bladder cancer. Dr. Mohammed Saifan, the floor is yours.
Assalamu alaikum. Good afternoon, everyone. I'm not sure if it's already evening. So first, I would like to thank Dr. Ashwag and congratulate her for the success of this event for how many times so far? I'm not really sure. So again, thank you, Safwan. Thank you, Dr. Amir, for the kind introduction. And I'm actually going to present the role, how to define first-line therapy in bladder cancer. So, okay. So first, I'm not going to go over the platinum eligibility, how we used to define our treatment option in the first-line advanced setting, which was defined by Galsky and his team. It's important to highlight, and maybe it addresses one of the previous questions from the panel, where we used to treat by MVAC, and this was the study that evolved or gave the option of GEMSIS as an equivalent option to MVAC with less toxicity and more tolerability. From these curves, you can see that GEMSIS did do as good as MVAC. And if we talk about whether to use cisplatin or carboplatin, you'll see that many studies have addressed this question, and the bottom line is giving carbo or cis would yield in at least two-thirds of these patients with an objective response rate, and it can reach up to almost 78 or 79%. So 7 or 6 years ago, the way that we used to manage is according to platinum eligibility, and that would be our first line. Second line would be taxane, and we have venflunine, which is only approved in Europe and not available here. So we learned later on that bladder cancer is actually the second or the third most the solid tumor with the highest tumor mutation burden, and hence many studies have addressed the question of incorporating immunotherapy either in later lines, which it began with, and moved to be as a maintenance or first line later on. So this is the way we managed in 2020 or 2021. First line platinum-based chemotherapy according to cisplatin eligibility. If the patient achieves disease stability, then he goes for avelumab maintenance. Otherwise, he goes for a second line pembro or atezolizumab. And this leaves ADCs and targeted therapy for FGFR as a third line or later. So we learned this by 2021. Then all the studies tried to push immunotherapy to the first line setting. And this have been addressed in multiple studies with different PD-1, PD-L1 combination, either in combination with chemo or as a dual immunotherapy in the first line setting. So then you have addressed Dorba versus Dorba-Tremi versus chemo, negative study. Keynote 361, again, Pembro chemo versus chemo, negative study. And the MVigor with atezolizumab or with chemo, again, negative study. Then we had Checkmate 901, and the dual immunotherapy combination is a negative, was negative. However, Nivo chemo was presented at the same time with EV302, shown to have survival advantage, but they were unlucky with the timing of this release. So far we have 3 approved first line options. Avelumab, which is considered the first line as it is maintenance after confirming disease stability. Then we have the EV302 and nivolumab from the Checkmate 901. So it's worth mentioning that, and here I'm not actually comparing these studies. However, they were all phase 3 studies, and there were slight differences in between. So Checkmate 901, for example, was only for those with cisplatin eligible patients, whereas both Javelin and EV302 did include both cisplatin as well as carboplatin eligible patients. The primary endpoint for Javelin was only overall survival, as this is only a maintenance phase and you don't expect PFS from immune therapy by itself. Whereas EV and the Checkmate did have a co-primary endpoint of PFS as well as overall survival. You can see that upper and lower urothelial cancer were more or less similar across all of these studies. And as expected, PD-L1 expression was in the up 50s in all of these trials. So the Javelin 100, and here I don't want you guys to look into the median PFS or median overall survival, as they were slightly different. So Javelin have actually started randomization after 4 weeks from the last chemotherapy, and then they started calculating their median overall survival. However, I think the best way to compare is actually hazard ratio, and it did achieve 0.76 and translated to a median overall survival of almost 24 months, 2 years from the time of randomization. EV302, you see how beautiful these curves are separated, and this have translated to doubling of their overall survival from 16 to 31.5 months, and it comes with a reduction in risk of death by 53%. How about Checkmate 901? You can tell that their curves is more or less similar to Javelin 100, as well as their hazard ratio with the 0.76. So to make it more or less fair, so how if we compare Javelin from the time of the get-go, from the time of the induction, yes, they do achieve median overall survival of almost 30 months. However, there is one caveat here, is that they did not include in the randomization those who progressed on chemotherapy, who harbored the most aggressive disease and worse prognosis. However, if you add on those who have with the super selected patients fit, and you think they will be able to go for second line, you can actually achieve 30 months with this kind of strategy. However, you don't have this kind of bias when you go by 302. And as I said earlier, their benefit is clear, straightforward, 31.5, despite stopping EV. The median number of cycles for EV were around 9 cycles, if I'm not mistaken. So coming to PFS, again, PFS, you wouldn't really be able to tell by Javelin because this is from the time of starting maintenance. However, clearly, EV302 did show a doubling of their PFS, where we see more or less similar PFS for Checkmate 901. However, it was statistically positive. If we talk about objective response rate, again, despite avelumab was given as part of maintenance, they did show an improvement in objective response rate around 10% after added to whatever you were actually achieved by the induction phase. And if you look into EVB, you see 2/3 of these patients achieved the objective response rate, with around 30% having complete response. If you look into Nivo chemo, you see 21%. And again, you have to keep in mind that this was only cisplatin eligible patients. So yeah, you'll take it because those patients do better with chemo, and it is cisplatin. So keeping in mind the treatment-related adverse event. So there is one thing that I did not correct, which is all of these studies have actually quality of life data. Even EV302, where they did show at least maintained with no deterioration by giving EVB compared with the control arm. However, we have to keep in mind the unique toxicity of enfortumab vedotin, which includes peripheral neuropathy. Some of them are actually with motor affection. Second, hyperglycemia. Third, the skin toxicity. And you have, especially for those who have comorbidities with pre-existing grade 2 peripheral neuropathy, I would be very cautious from giving any kind of enfortumab vedotin, which might actually cripple these patients. So for these patients whom are maybe by inclusion candidate for EVB, but still, I think if you have any kind of pre-existing peripheral neuropathy, grade 2 or higher, with uncontrolled diabetes, I think the best option is actually this trial, the DISCUSS study, which was presented in ESMO last year, where they did show a similar design to Javelin 100, however, with 3 cycles versus 6 cycles, with the primary endpoint being quality of life. And we see that the quality of life with 3 cycles were actually better than those who received 6 cycles of platinum. And it did not translate to any difference in terms of overall survival. So for frail, elderly, pre-existing peripheral neuropathy, I think that's the way to go, starting with perhaps with the 3 cycles carboplatin-based chemotherapy, followed by avelumab maintenance. So this is where we stand currently. We have to define again cisplatin versus carboplatin, just for the Nivo, as Nivo only included cisplatin eligible patients. And for those whom are non-platinum eligible, their option would be either pembrolizumab or best supportive care. However, so these studies did not compare themselves to each other. The best way that we can do is actually look into a meta-analysis. This was actually presented in mid-2025, and they did include all kind of patients profile with different studies. So I think we have a clear winner. EVB is the best in terms of this kind of strategy in the first line setting, followed by avelumab, followed by Nivo, which are those are the medications that we have actually approval for. However, if we look into more of segregation or into different subgroups, you'll see that on the left, A is those with cisplatin eligible, and EVB is the winner, followed by, you'll see a similar hazard ratio for both atezo-gemcis and avelumab-gemcis. On the right, you'll have those with carboplatin eligible patients, And here it is EVP, the second best option, and those are the only two positive in terms of statistical analysis, is avelumab gem carbo. So if the patient is frail, and this actually comes to my previous slide, frail, pre-existing peripheral neuropathy, uncontrolled diabetes, the way to go would be actually a carboplatin-based combination followed by avelumab maintenance. So how about PD-L1? We know that none of these treatments is approved or guided by PD-L1. However, for those with PD-L1 positive disease, the best in terms of outcome is EVP, followed by avelumab. And if you go for those with PD-L1 negative, it is EVP, followed by actually Nivo Gemcis. So taking this all into consideration, I think we have to, there is no clear winner. I think each patient has its own patient characteristic, and you'll have to choose accordingly. So you have to keep in mind the frailty, comorbidities, tumor burden, preference for the patient, fitness, and quality of life to choose from all of these options. So coming back to carbo as an option with avelumab maintenance, maybe only 3 cycles. So there is a post hoc analysis for the Javelin bladder where they did show significant benefit even for patients older than 80 years of age. Those with obesity, with high PMI, as if you consider EVB for those with obese patients and give them the highest dose of EV according to weight, this might be actually toxic. Coming to uncontrolled diabetes, we all have experience giving platinum to patients with diabetes with no concern. And lastly, how to sequence these treatment options. So now it was easier like a year ago where we didn't have Niagara, we didn't have EVP and MIBC setting. So how to choose from these options nowadays? So first we'll have to consider, did they receive prior immune checkpoint inhibitor with chemotherapy such as Niagara? And here, if the answer is yes, and they haven't received the prior EV, then the option would be EVP or EV alone. However, it would depend on the time or the treatment-free interval from the last immune checkpoint inhibitor. If EV is not available in your center, then your only option would be chemotherapy combination. So how about those who received the EVP in their either neoadjuvant or adjuvant setting as a perioperative? Then your only option would be actually platinum-based chemotherapy according to patient fitness and platinum eligibility. And then you would consider FGFR if the patient harbors FGFR, or HER2 targeted therapy if they are HER2 positive. Lastly, for those who have received an adjuvant immunotherapy based on Checkmate 274 or the Ambassador trial, then again, you'll have to look into the treatment-free interval from last immune checkpoint inhibitor. If it is more than 6 months, then EVP again is the best option. If not, EV is not available, then you'll have to go with the platinum-based chemotherapy again. So how did this incorporate to the guidelines? This is the latest from ESMO 2024, and you see a clear winner on the left, EVB for those with once it's available and the patient is treatment naive. However, on the right, you see when EV is not available, then you'll have to stratify your patients into cisplatin versus carboplatin eligibility. If they are cisplatin eligible, you have the Nivo option. If carbo or cisplatin was given alone without Nivo, then patient achieving stability will go with avelumab maintenance. Otherwise, they will go to a second-line immune checkpoint inhibitor with pembro or atezolizumab. And finally, upon progression, you have all the options from FGFR, HER2 targeted therapy, etc. So this is the ESMO. However, if you look into the EAU 2023 and compare it with 2024, you'll see the clear difference and how did we evolve within just a year. So on the left, we had the prior classification from carbo and cisplatin eligibility, whereas in 2024, EVP is the best option. And then according to patient characteristic and availability, you may actually consider Nivo or avelumab maintenance afterwards. So my take-home messages are there have been a remarkable advancement in the management of first-line metastatic urothelial bladder cancer. Currently, we have 3 approved options, and we need to choose wisely according to our patient profile and characteristic. And the second-line treatment option would depend on what you have given them earlier, either an IO anti-VEGFR or an ADC. There are actually only 2 ADC currently approved, EV as well as TDXD. SG was previously approved, however, they have withdrawn their registration given their negative result in the first-line setting. And with that, I conclude. Thank you.
Thank you so much, Dr. Mohammed, for this excellent presentation and analysis of the different options of the treatment of metastatic urothelial carcinoma. So we'll have some questions and discussions. So maybe I will start, Mohammed, for this. You mentioned that after adjuvant immunotherapy, you will give EV pembro. So do you think this will not affect the efficacy of this regimen if you give prior immuno?
Thank you, Dr. Amin. So to be honest, there is no evidence when it comes to first-line setting after incorporating immunotherapy early on with Niagara and all the other studies available there. So we did see clear synergy and extremely excellent result in the first-line setting from EB302. So similar to almost all tumor sites, except for renal cell, we don't have a clear answer whether we can actually re-challenge with immune therapy. However, for the time being, we have an amazing result in the first-line setting from this combination. And for that reason, if they haven't received the prior EV, I would consider a possible synergy with the immunotherapy if they are at least 6-month treatment-free interval from the last immunotherapy. But EV alone is also a very wise option. I have to state this.
Thank you, Dr. Sarafan. I have a question for Dr. Mohammed Al-Khamis. So one thing is CIS. We focused on CIS on your presentation. For us as medical oncologists, we know that CIS is a prognostic factor. But as a urologist, what do you do when you see CIS? Do you actually intensify treatment, or do you actually have a different algorithm in terms of, you know what, this patient is going to go for cystectomy no matter how many times they're going to give BCG or go for resection?
This is an excellent question. So if you have a patient with high-risk non-muscle invasive disease, you need to have a look. Is it predominantly papillary with the focus of carcinoma in situ, or it is multifocal carcinoma in situ with a little bit of papillary urothelial cancer? We do know that BCG works very well. That's why it's been there for a very long time, and it's staying also with us as a medication because it has a good effect on carcinoma in situ. However, patients with multifocal carcinoma in situ have worse prognosis, higher rates of failure of BCG, and probably higher rates of progression to muscle invasive disease. So that will not change the management initially. We will always go and challenge the BCG induction and long maintenance for 2 to 3 years. And if they recur, then we say if it's multifocal carcinoma in situ, the better served with cystectomy. With this change, with the current intravesical era that we look at, not in the guidelines yet, but I think I'm very optimistic that certain medications that we talked about today will show us benefit in this patient population.
With the global shortage of BCG, if at any time you didn't have access to BCG, what would be your option currently?
So in COVID era, that was the BCG shortage time when we really were struggling locally, like nationally and internationally. That was difficult times. We started shifting our patients to mitomycin, intravesical chemotherapy, but not anymore. In the past couple of years, BCG had been around multiple vendors, multiple countries are producing BCG, so it's not an issue anymore. However, if that happens in any country, then intravesical mitomycin with the enhanced delivery system, either heated or EMDA electromotive mitomycin would be a good alternative. Gemcitabine. But the problem with gemcitabine is the durability. It doesn't cost, it will be like a bridge for you until you have your final plan. But gemcitabine does not have a very durable effect, even when docetaxel was added to it. I would give the patient Bembro, systemic Bembro as compared to local gemcitabine. Yeah. Yeah, this is the buzzing news now. The Saudi FDA approval for Ankiva. So it is approved, but after BCG, up to my knowledge, after BCG, BCG still is the standard of care as a first line for high-risk bladder cancer. And if the Ankiva research did not show very, very great benefit being as a monotherapy by itself. However, when it's combined with BCG, the augmentation of immune effect is promising. That's a problem. People are advertising it as a cure now by itself for localized and systemic metastatic muscle-invasive bladder cancer.
Dr. Saifan, thank you very much. I have a question regarding those patients used in the local advanced disease perioperative Bembro enfortumab, and they achieve long disease-free interval. I mean, more than 2 years. Do you consider in the metastatic to use the same regimen Bembro enfortumab, or your preference to give chemotherapy if the patient progressed?
So again, this is an area with no clear data. However, if the patient have completed the adjuvant part of EVB or whatever, or new adjuvant, and did stay for longer than 1 year without recurrence, then I would definitely attempt the same combination upon recurrence or upon progression.
And if you use chemotherapy, you will continue avelumab maintenance.
So it depends. So if I choose, if the patient was off treatment for more than a year and still candidate for EVB, my best option would be EVB, to be honest. If for any reason patient was deemed not fit or not candidate for EV, then I'm gonna give carbo gem, and then I will follow it by avelumab maintenance. Yes.
Thank you.
Yeah, I have 2 questions. One to Dr. Al-Khamis regarding those patients who has diverticular disease and who's refusing surgery and systemic treatment. In terms of the intravesical treatment, do you have any specific approach for those patients?
Now, this is a quite challenging population because on pathology and on paper, those patients are non-muscle invasive disease. Actually, but if you think about it, the verticular disease harbors no muscle. So in essence, they are in between muscle invasive and non-muscle invasive disease. If there is no clear radiological evidence of T3 disease involvement of perivesical fat, then there might be a role for intravesical therapy. But you have to tread very slowly with those patients. The risk of progression is very high. There are not many muscles around the bladder and the verticulum to protect from quick spread. So if you decide to give them intravesical therapy, I would still go with the standard BCG with aggressive surveillance. And if they show any signs of early recurrence on BCG, I would attempt surgery. And the surgery is an open for discussion. So partial cystectomy might be a good option for those patients with very strong surveillance. If the patient agrees, then radical cystectomy would be the best option. But partial cystectomy to decrease the need for removing the whole bladder and urinary diversion would be definitely an option.
Excellent. For Dr. Saifan, regarding the EV Bembro in terms of toxicity, especially the skin manifestation, both of them can cause skin manifestation. So if you have patients who has developed one of those, the skin manifestation, how's going to be your approach in terms of which treatment you will continue and which treatment you will discontinue?
Sure. So great question. So immunotherapy by itself has a long half-life. So you wouldn't actually attempt holding Pembro, for example, early on. hold EV to begin with, give all the supportive treatment with antihistamine, local steroid, and according to the rate of the skin toxicity, you might actually add oral steroid if patient did not recover. Or so you will attempt initially EV treatment holiday. If it works, then it is EV, and you'll re-challenge again with EV if it will give you the answer. Otherwise, if the patient did well and you re-challenge with the immunotherapy, and you'll get your answer. But I would start by holding EV before immunotherapy.
So will be the option of re-challenge with AV there if it's like responding after discontinue the AV? Or?
It depends on the grade. So grade 1, grade 2 that you can actually control with local treatment and antihistamine, I would definitely continue and re-challenge with EV. Whereas if you have more even grade 3, you can actually re-challenge. But it depends on the grade and the leaflet, how to actually manage the skin toxicity of EV.
Excellent. Okay, thank you.
Maybe I have a last question for Dr. Al-Khamis. So if you have a patient who basically has a non-muscle invasive and you cannot resect it, would you actually go and try to get muscle? Because I have a patient where we discussed in our tumor board, our urologists say, you know what, we cannot get to the muscle whatsoever. And MRI also does not confirm that there is muscle invasion. And then at the same time, it's not resectable. So I'm pretty sure you guys are facing same scenarios. So what do you guys do about those patients? From a medical oncology standpoint, I cannot give him localized treatment or bladder sparing treatment because I don't have evidence of muscle invasion. At the same time, I cannot treat him as metastatic because he doesn't have metastatic disease.
This patient population is quite challenging because you have a patient when he comes to him in the clinic and you tell him you have a non-muscle invasive disease and your only option now is removing the whole bladder. But unfortunately, we are left only with this option. Now, in the era of MRI now or advanced diagnostic imaging, MRI is pretty sensitive in detecting muscle invasive disease, especially if you do it in 4 to 6 weeks after your first section. So if it does not, the easy answer is if MRI is suggestive of muscle invasive disease, then it's a chat that we have in the MDT with our oncologist. If he's happy, based on the radiological evidence, to go ahead with neoadjuvant chemotherapy, then we will go that pathway followed by cystectomy. If the medical oncologist is still hesitant to give neoadjuvant based on radiological findings, then we will go ahead with cystectomy. However, when you come with patient, like you mentioned, he doesn't have muscle invasive disease on MRI, then it's irresectable by TURBT, either due to multifocality, difficult location, because tumor might be anywhere in the anterior wall where it cannot come, or there are anatomical challenges for the resection endoscopically. So the only option at this time is cystectomy. And it's a difficult counseling for the patient, but we do like, I would say 10 to 15% of our patients who undergo robotic cystectomy in our institution are patients who have irresectable disease. And this is your only option. And you will be surprised that you will get muscle invasive disease on the specimen afterwards.
Thank you. Any further questions? Okay, so if there is no further questions, we'll conclude this session. Thank you for the speakers, and thank you, Dr. Tijani. And we'll move on to prayer and break. Thank you.
السلام عليكم ورحمة الله. Walaikum salam. So it's not a break?
وعليكم السلام.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. طيب, we would like first to thank our best friends from National Guard in Riyadh, Dr. Shwaq Al-Ayyan, Muhammad Al-Qadni, and the whole group for keeping us part of this great gathering in Riyadh. This session is about prostate cancer. I'm co-chairing this session with my friend, Dr. Ibrahim Al-Shanqiti from King Fahd Hospital in Dammam. He's with us online. Dr. Ibrahim, are you with us? He was texting me. I think.
المعذرة منكم أنا معكم موجود حسبت إنه بريك حياكم الله جميعا. I'm happy I'm here today. عماد take over for 5 seconds عندي ER call.
Okay. So allow me to introduce the first speaker, Dr. Rola Mufti. He's a well-known oncologist from King Faisal Specialist Hospital in Jeddah. She will be talking about targeted therapy in prostate cancer.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I would like to thank Dr. Ashwaq Al-Ayyan and our colleagues in National Guard Riyadh for their kind invitation. I'd like to congratulate them for the successful meeting. And I've been asked to talk about targeted therapy in prostate cancer. So as we always brag, all GU oncologists, that prostate cancer has always been a targeted therapy area in oncology, and this is not new to any of us. As for prostate cancer in Saudi Arabia, it is the second most common malignancy in male population of patients. And as I was telling you, why prostate cancer has been treated as or considered as targeted therapy from the beginning. Because since Charles Huggins discovered orchiectomy in the 1960s, we knew that this disease is a disease that's controlled by hormones, and thus it responds very well to them. So if we talk about the definition of metastatic castration-sensitive prostate cancer, the de novo disease or the synchronous is the first diagnosis with metastasis without prior treatment, and the relapsed or metachronous is the diagnosis of metastasis only after local radical therapy. And if we look at the development and the landscape evolution of metastatic hormone-sensitive prostate cancer, from the 1980s, we started only with ADT, androgen deprivation therapy, and then we had docetaxel up to 2015. And afterwards, from 2015 onwards, we had a plethora of new androgen receptor blockade therapy that included the abiraterone that was approved by the Stampede and Latitude trial. And then we had the enzalutamide that was approved by the ARCHES and ENZAMET trial. And then we had the Titan trial for the apalutamide, and finally the darolutamide in the ARANOTE trial. And this is only for the treatment with androgen receptor inhibitors. And in the past couple of years, we had 2 trials that combined docetaxel, the PEACE-1 trial and the ARASENS trial. They both combined chemotherapy docetaxel with either abiraterone and ADT or darolutamide and ADT. So moving on to androgen receptor pathway, as I mentioned, we have the abiraterone, the enzalutamide, the apalutamide, and the darolutamide. They are used in different situations in metastatic hormone sensitive, in non-metastatic castration-resistant prostate cancer, or in metastatic castration-resistant prostate cancer. And no biomarkers are required for all of those treatments because we know that they work on all adenocarcinoma of the prostate. So the triplet, as I said, with docetaxel plus darolutamide or abiraterone was approved just in the past couple of years after the PEACE-1 and the ARASENS trial. And I will not talk a lot about that because we have a bit more interesting and newer topics that includes the DNA damage repair and the PARP inhibitors. And we have multiple PARP inhibitors that were used and approved in metastatic prostate cancer, especially in the castration-resistant era, the olaparib, the rucaparib, the talazoparib, and they are all for patients with HRR mutation that includes BRCA1 and 2, and they are the best responders. We have other mutations like PALB2, ATM, CHEK2, etc., that include the homologous recombination repair pathway mutation genes, and those also respond to PARP inhibitors, but to a lesser extent. So what is new for us now? The new information that we learned from the ASCO 2025 is that there is a role now also for PARP inhibitors in the castration-sensitive, and this was presented in the phase 3 amplitude trial for niraparib and abiraterone acetate plus prednisone for metastatic castration-sensitive prostate cancer in patients with alteration of HRR repair genes. So this was a large trial. It included more than 690 patients. All of those patients, they had alteration of at least one gene that included the BRCA1, 2, BRIP1, CDK12, CHEK2, FANCA, PALB2, BRAD51B, BRAD54L. And they were randomized to either receiving niraparib, niratinib, plus abiraterone acetate and ADT, or placebo plus abiraterone acetate and ADT, and the primary endpoint was rPFS. So this study met its primary endpoint, and the radiographic progression-free survival was significant in both the intent to treat population, I mean all of the mutations, with a hazard ratio of 0.63, and the benefit was even more pronounced as in the all other trials in the BRCA mutation population. As you can see here in green, we can see that there's a very nice separation of the curves favoring niratinib plus abiraterone acetate, with a benefit with reduction in the risk of radiographic progression or death by 48% in the BRCA mutated population and 37% in the intent to treat population. This also, the study met its primary endpoint also for overall survival, though still the results needs more maturity, but still we can see clearly that there is a reduction in the risk of death for BRCA mutation by 25%. Which is statistically very significant, hazard ratio 0.75, and it was 21% for the HRR mutation population of patients. So this is a practice-changing. Trial. Again, it made it primary and another secondary endpoint, time to symptomatic progression. Again, 56% reduction for the BRCA mutation arm and 50% for the HRR mutation arm. And looking at the safety profile, we can see that 75% of the patients had grade 3 or more side effects in comparison to almost 60% in the patients receiving abiraterone acetate. We know that abiraterone acetate is not the easiest treatment from the androgen receptor inhibitor treatments. And we see that 15% almost of the patients had discontinuation versus 10% in the abiraterone and ADT arm. Of the most common side effects was anemia. It was quite significant, reaching 50% of all grades and around 30% for grade 3 and more, which is class medication common for the PARP inhibitors, and hypertension as well was significant in this study. Surprisingly, it was not surprisingly, it's expected to see that it was more pronounced in the combination of neratinib with abiraterone acetate. We have other trials, older trials that they were also positive for PARP inhibitors. The TELAPRO-2 trial that established another medication, but here we are talking about the castration-resistant population. So the amplitude trial was in the castration-sensitive. Now this was tested in a phase 3 trial in more than 800 patients in the castration-resistant population, and those patients were randomized to talazoparib plus enzalutamide or enzalutamide alone, and this was a positive trial reaching its primary endpoint with an overall survival median of 45.8 months versus 37 months for the enzalutamide arm, with a hazard ratio of 0.79 for overall survival. And also it met its primary endpoint for radiographic progression-free survival with a hazard ratio of 0.667. And this is for all comers. Of course, if we look at the overall survival for the patients with HRR mutation and patients who do not have HRR mutation, you can see clearly that the hazard ratio is significantly better for patients with HRR mutation, and we can conclude that the benefit that was seen in this trial was withdrawn from this population, and the non-deficient patients had a hazard ratio of almost 0.9. So there is a huge difference between them. So this became also an option for patients with castration-resistant prostate cancer with HRR mutation only. Another trial, a previous trial, the PROPEL-3 trial, that gained the FDA approval for the BRCA-mutated population of patients, looked at more than 790 patients with metastatic castration-resistant prostate cancer, and again, it compared olaparib plus abiraterone versus abiraterone alone. And the BRCA-mutated population of patients had an rPFS with a hazard ratio of 0.24. This is an unprecedented number, while if you look at the non-BRCA mutated population, which were more than 700 patients, the hazard ratio for the rPFS was 0.77. So there is a huge difference in the benefit for this population. And the same applies for the overall survival. 70% reduction in the risk of death with a hazard ratio of 0.3 for the BRCA mutated, while only a hazard ratio of 0.92, just less than 1% difference. So the FDA only approved this combination for patients with BRCA mutation. They did not approve it for all comers. So these are the different trials that we had so far, the new trials, and we're going to talk about them a bit further on. So more on the targeted therapy in prostate cancer, we have the lutetium PISMA 617, and this again the approval after the VISION trial, and the VISION trial was for patients with metastatic castration-resistant patients who are heavily pretreated population of patients, received it was the third line or further for them, and they were randomized 1:2 to either receive the lutetium or any standard of care that was provided by the investigators. Lutetium was 7.4 GBq 6 weeks, and the study met its primary endpoint, and there was an improvement in the event-free survival for patients who received lutetium, as you can see here, with a median of 15.3 months versus 11.3 months. So this was a positive trial. And again, this is a medication that is unfortunately a bit toxic, and the toxicity occurs in around 5% of the patients, with serious side effects occurring in 10% of them, almost. And the most important side effect is bone marrow suppression that includes anemia, leukopenia, and thrombocytopenia. Other side effects includes nausea, vomiting, and dry mouth. So another more recent trial that was presented just recently in October 2025 in the ESMO was the phase 3 PISMA addition trial. And this phase 3 trial combined lutetium PISMA with ADT and anti-androgen therapy for patients with metastatic hormone-sensitive prostate cancer. And this trial included a large number of patients. They were a previously untreated population of patients, and they were randomized to either receive lutetium up to 6 cycles, Q6 weeks, plus ADT plus ARTA, versus patients receiving only ADT and ARTA, and docetaxel was not allowed in this trial. So the primary endpoint was RPFS. And the study met its primary endpoint. And as you can see here, that the hazard ratio for RPFS was of 0.72, and there was 28% reduction in the radiographic progression-free survival for this population of patients. The overall survival data is still quite immature, but we can see that the curves start to separate with a hazard ratio of 0.8 or at the time of cutoff analysis. But we expect better results with time, especially in the metastatic HSPC population of patients. So moving on to more emerging data on the PIK3CA and AKT pathway. This includes the PTEN mutation. We have some newer medications that are under investigation, the ipatasertib and the capivasertib, for patients with PTEN loss. And still, we don't have a standard of care, but we have a very, very recent data from the ESMO 2025, from the Capitello 281 trial that was presented by Dr. Fizazi, a phase 3 trial of capivasertib plus abiraterone versus placebo plus abiraterone in patients with PTEN deficient de novo metastatic hormone-sensitive prostate cancer. And this looked particularly at patients with PTEN deficiency, and there was these were patients with PTEN deficiency and de novo metastatic HSPC, and they were randomized to receive capivasertib plus abiraterone plus ADT versus abiraterone and ADT, more than 1,000 patients, and the primary endpoint was RPFS. So this study met its primary endpoint with a positive hazard ratio for radiographic progression-free survival of 0.81, 33.2 months for capivasertib plus abi versus 25.7 months. So we have at least or more than 7 months benefit in RPFS for this population of patients. Still, the hazard ratio is still immature, but there is a trend to have a separation of curves. So this is a new medication. Of the most important adverse events is diarrhea, hyperglycemia, rash, anemia, hypokalemia, hypertension, and fatigability. Moving on to immunotherapy, and just for the sake of time, I will be fast on this part of the talk. As we know, a couple of years ago, pembrolizumab was approved in the use for patients with MSI high, and this occurs, unfortunately, only in up to maximum 5% population of patients. We do test our patients for MSI high, but unfortunately, it is quite rare to occur. And this was demonstrated in the Keynote 199 trial that showed benefit for using pembrolizumab in this population of patients. If you have a patient with MSI high, then pembrolizumab is your treatment of choice. And the second trial for immunotherapy Of course, we had a couple of trials combining pembrolizumab with olaparib and other trials that are not quite significant or in positivity point of view. We have a more recent trial, the CONTACT-02 trial, which was a phase 3 recent trial that combined cabozantinib with atezolizumab. It unfortunately did not demonstrate overall survival benefit. This trial was for metastatic CRPC patients, and when the results the study was positive for radiographic progression-free survival with a hazard ratio that was actually quite significant of 0.65. Most experts think that the benefit is withdrawn from the cabozantinib rather than the atezolizumab, but anyway, this is not approved yet. It did not have any overall survival benefit. It was very minimal, a hazard ratio of 0.89. So moving on to bone-targeted therapy, the radium-223 was approved quite a while ago, from 2018. It is a calcium mimetic, and this treatment was approved after the ALSYMCA trial. And this trial was included more than 900 patients, and these patients had only bone metastasis. This is very important to note, and they were randomized 2-to-1 to either radium-223 or a placebo, and the trial was positive for overall survival. It improved the overall survival 14.9 months versus 11.3 months with a significant p-value and a hazard ratio of 0.7, a 30% reduction in risk of death. So this, as we said, a more recent trial is the ERA-223 trial that added the radium-223 in combination with abiraterone acetate, and this trial was positive but was very, very toxic. We had a high risk of fracture, so it was not approved as a standard of care. A more recent trial is the PEACE-3 trial for patients with metastatic castration resistant prostate cancer that was presented in the ESMO 2024. More than 400 patients were randomized 1-to-1 to receive radium-223 plus enzalutamide versus enzalutamide, and this trial also was a positive trial with a positive hazard ratio of 0.69, so almost 31% reduction in the risk of radiographic progression-free survival, and the overall survival for this trial was also positive, with almost also 30% reduction in the risk of death. So this is a new trial that might change also the practice for patients with bone-only metastasis. The most important, you have to see the most important adverse events: hypertension, fatigability of fractures, anemia, and neutropenia. Again, it is much less significant than when it was combined with abiraterone. Finally, for patients with metastatic prostate cancer, targeted therapy still is very important pathway, but it depends a lot on the biology. We have to never forget that the androgen receptor pathway is the most important backbone for treatment of adenocarcinoma. Genomic testing is extremely crucial and important, as well as testing for MSI. Thank you so much for listening.
Thank you, Dr. Arula. That was extensive and a great presentation as usual. I'm Abdulhamid Shanqiti. Welcome, everyone. I want to thank our friend in National Guard, especially Dr. Ashwaq, Mohammed Al-Girni, Nafisa, and Kanaan, and as well Ahlam and Jason for the great arrangement as usual. And I'm sorry I did not make it. We're happy to continue rolling for prostate cancer and to talk about the role of PSMA scan in the management of prostate cancer. The best to give us this lecture is my dear friend, Dr. Faisal A'zam, medical oncologist and researcher and the head of the GU group in Dammam, with great experience in prostate cancer. Dr. Faisal, the floor is yours.
Bismillahirrahmanirrahim. Thank you, Abdul Rahim, and thank you, Ashfaq and Muhammad, for organizing this meeting and organizing committee for asking me to talk about the role of PESMA scan in the management of prostate cancer. So these are my disclosures. So I'll start my presentation with one of the history of my patient who has a prostate cancer. He's a 68-year-old. Gleason score of 8 and his initial PSA was 12. So he was treated with radical prostatectomy, and because of the positive margins, he was offered adjuvant radiotherapy. Even after prostatectomy, he has achieved undetectable PSA, but he was given radiotherapy. And after radiotherapy, because his PSA was undetectable, so no ADT was given, and he was under follow-up with the urology team. And after 9 months, the PSA started to rise. And every 3 months, they were monitoring the PSA, and the readings are 0.3, 1.2, and 2.8. CT scan, bone scans reported no metastases in either of those investigations. So their diagnosis was non-metastatic hormone-sensitive prostate cancer with biochemical relapse, referred to the medical oncology for systemic therapy. So when we saw this patient, we requested PESMA gallium PET scan, and the results were different now. So there were 2 lymph nodes, 5 millimeter each, an SUV max of 8.2. They were pelvic lymph nodes, and there was one solitary left iliac bone metastases, SUV max of 12.4. Now these lymph nodes were not seen on CT scan, and the bone metastases were not seen on the bone scan. So our diagnosis, which before was non-metastatic hormone-sensitive prostate cancer, now has changed to metastatic hormone-sensitive prostate cancer. But the patient had oligometastases, only 3 metastases as reported on the PESMA scan. So PESMA scan can change the definition, but not only definition, also the plan of treatment. So this patient was basically referred to us to offer systemic therapy, and after discussion with urology, they were thinking we should offer doublet therapy because it's a metastatic disease, or a non-metastatic biochemical relapse. But then when we discussed in the MDT, and because of only 3 metastases, it was decided that patient should have stereotactic body radiotherapy to the lymph nodes and bone lesion. When we did that, the PSA became undetectable, and so we deferred systemic therapy. So you can see how the management was changed because the PSMA scan has helped us to give the metastasis-directed therapy. So PSMA PET scan identified actionable disease missed by the standard imaging. It enabled us targeted metastasis-directed therapy, and we delayed the systemic therapy. And of course, when you start the doublet therapy for those patients, or even ADT, it has to be long-term, and it has significant side effects. So this patient was prevented, or we did not start any systemic therapy, and so we prevented him from all those side effects which can happen with ADT or ARPIs. So what is PSMA? PSMA is a transmembrane glycoprotein highly expressed on the prostate cancer cells. And when the radiolabeled ligand binds to this PESMA receptors, it enables the visualization on the PET scan. The higher the expression of the PET in the cancer cells, the more aggressive is the tumor. Conventional imaging is not good for small metastases or early metastases because of the limited sensitivity. All CT scan, MRI scan, and bone scan are the standard imaging, what we do usually, but unfortunately, it is not helpful for early metastases. But PSMA PET scan has revolutionized the staging, restaging, and even it is helping us to manage our treatment more appropriately. There are 3 tracers currently used for PESMA PET scan. The most widely is gallium-68, but we have PYL, it has a longer half-life, and PSMA 1007. But most commonly, we use it in our hospital also. We are using PESMA gallium-68. And there are few trials which has confirmed that doing PESMA scan is much superior, more accurate than conventional imaging. PRO-PESMA is the trial which compared to conventional imaging, and Condor and Osprey studies reported that in those patients who had a biochemical recurrence detection were highly possible with the PESMA PET scan, which was not possible with the conventional treatments or conventional imaging. And then Vision trial was discussed by Rula, which is a lutetium PSMA therapy improving overall survival and progression-free survival in patients of castrate-resistant prostate cancer after using ARPI and docetaxel chemotherapy. Then another trial, PSMA-4, has moved the lutetium therapy earlier, only after ARPI, but before chemotherapy. And more recently, in metastatic hormone-sensitive prostate cancer, they have used lutetium PSMA in a triplet therapy using lutetium PSMA, ARPI, and ADT. So I'll discuss the PRO-PSMA trial first, which is a phase 3 study. And they have included those patients who were high risk and for a curative treatment. PSA score of more than 20, Gleason score of 3 to 5, or clinical stage of more than 3. And they have randomized 302 patients. The first group was patient who had the conventional imaging of CT scan and bone scan, and the other arm was a patient who had PESMA PET scan. And then whatever the findings were found on those scans, they were confirmed on another scan. So those patients who had CT and bone scan had PESMA PET scan, and those patients who had already had PESMA gallium PET scan, then they had CT and bone scan, just to confirm the accuracy of these scans. So on a CT scan and bone scan, they found 65% of metastases, while on a PESMA gallium scan, they found 92% metastases. So that means 27% greater accuracy with PESMA PET scan as compared to the conventional imaging. Sensitivity was 85%, specificity 98% for metastatic disease or nodal metastases, and it detected lesion as small as 2 to 3 millimeter only. It detects nodal and distal metastases, which is usually missed by the conventional imaging because they are too small. And in the trial, they found that 30% of the patients were upstaged because we did the PESMA PET scan. It, of course, influences the treatment, which can be local curative treatment or systemic therapy. It's quite sensitive even at the very low PSA, like 0.2 nanogram per ml, but detection rate increases when the PSA level is high. 40% detection rate when the PSA is between 0.2 to 0.5, but the detection rate becomes more than 90% if the PSA level is more than 2. It guides us to treat patient with salvage radiotherapy or metastatic directed therapy like our patients. So we avoided systemic therapy because of the PESMA PET scan. And if we see the charted and latitude classification of low risk or high risk or low volume or high volume, and if you use PESMA scan now, those definitions will definitely change. It helps us to select the patient for lutetium PSMA. If the patient is positive, then they can be treated with lutetium PSMA also. Another study is a Condor study. It's a phase 3 study. It evaluated the PYL PET scan to see it can change the clinical management in a patient who had a biochemical relapse. So 208 patients who previously were treated for curative treatment now had a biochemical relapse, and those patients were included who had more than 0.2 of the PSA after surgery or more than 2 after radiotherapy. So PYL PET scan detected and localized a recurrent disease across wide range of the PSA. This is the study design. They did the PYL PET scan on the day one of the study, and then there were 3 readers who have read it, and they were blinded readers. And then this information was given to the treating physicians, and it was at the discretion of the physician to treat those patients, observe this patient, give radiotherapy, or whatever management they want to do. But on day 60, they would assess again those patients and would do biopsy to confirm that those metastases which are present are definitely due to prostate cancer. If biopsy is not possible, then they would do conventional imaging. And those patients who have received radiotherapy, then they would do PSA to find out if the PSA change has been noted or not. So 3 independent blinded reviewers were assigned to review those scans, and the correct localization rate was more than 84 to 89% across these 3 blinded readers. At least one recurrent lesion was localized in 60 to 66% of the patient, and 64% of patients had changed in the intended clinical management because of the PYL PET scan, which was either to start the systemic therapy, salvage local treatment, or observation. Right. So we've said that PET scan can detect or diagnose very early metastases. It can change the plan of our treatment, but of course, like anything else, it has its own limitation. Like false positives are possible in benign ganglia fractures. It can come back as positive while it is not metastatic. False negatives can be found in dedifferentiated or neuroendocrine prostate cancer, and the biggest barrier is the cost. In most of the region, it's not available because of it's expensive. So it is helping us to treat the patient with the lutetium PSMA treatment, which is a targeted therapy. As I mentioned to you, VISION trial has shown to improve the overall survival and progression-free survival after ARPI and chemotherapy when we use lutetium PSMA therapy. PSMA-4 only after ARPI, but before chemotherapy, have shown to improve the progression-free survival, but overall survival is immature. And PSMA addition is a triplet therapy with ARPI and ADT in the metastatic hormone-sensitive prostate cancer, shown to improve the progression-free survival. This has already been discussed by Rola, but I'll just briefly say it's a phase 3 study where patient who previously had ARPI only but not chemotherapy were randomized to receive lutetium PSMA or change in the ARPI. Those patients who had change, who were in the group of the change in the ARPI, if they had radiographic progression-free survival, they were allowed to cross over to receive the lutetium PSMA. So total of 585 patients, 468 met eligibility criteria. Median number of cycles of lutetium was 6 cycles. Patient assigned to ARPI change, 57% of those patients crossed over to receive the lutetium PSMA, and that is why the overall survival data is diluted. Anyhow, the primary endpoint was radiographic progression-free survival, and it was doubled. 11.6 for lutetium PSMA and 5.5 for ARPI change. Generally well tolerated as compared to ARPI, so more or less similar. Again, this is also discussed. I'll very briefly go through it. It's a phase 3 study presented in ESMO last year using triplet therapy using lutetium PSMA, ADT, and ARPI versus doublet ARPI plus ADT in patients with metastatic hormone-sensitive prostate cancer in first line. Study is positive in terms of progression-free survival, favoring using lutetium PSMA in metastatic hormone-sensitive prostate cancer with ARPI and ADT. Then this progression-free survival benefit was seen across all groups of patients. Objective response rate of 57% versus 42%, favoring using lutetium PSMA initially, along with ARPI and ADT. Time to PSA progression. PSA nadir was significantly higher, nearly 15 or 16% higher than the doublet therapy. Time to symptomatic skeletal events, time to metastatic castrate-resistant prostate cancer, and progression-free survival by investigator, all favoring using lutetium in metastatic hormone-sensitive prostate cancer with the doublet therapy of ARPI plus ADT. Now, overall survival data is still immature, and still we do not have any data yet, but it seems to be the trend is that it will favor lutetium therapy. The toxicity or adverse events, the most common one which we usually see with lutetium PSMA, dry mouth, nausea, constipation, decreased appetite, vomiting, diarrhea, and taste changes were seen. But if you look at the grade 3 or more, they were 0. So it is mostly grade 1 or grade 2. Another common side effects are cytopenias, and anemia were more common, which is generally we see in the with lutetium PSMA anyhow, but neutropenia and thrombocytopenia were also seen. Grade 3 or more were considerably less common. So just to conclude my talk, plasma PET imaging is transforming the prostate cancer management. It provides superior accuracy for staging, recurrence, and therapy guidance, and it's an integral part to the future theranostic strategies. It is guiding us for the radioligand therapy, especially lutetium PSMA therapy. And now dual tracer imaging is in the process where they are using PESMA gallium plus FDG to be more accurate, because the PESMA-4 study have used both PET FDG and PET gallium. So here they are making now a dual tracer imaging to be more accurate than just gallium. And then AI is also have some role in interpretation of the PESMA scans. These are references, and thank you very much.
Thank you, Dr. Faisal, for the nice presentation as usual. And moving now to the art of selecting your treatment in the next step, which is castrate-resistant prostate cancer. And for that, the best to give us the lecture is my dear friend, Dr. Nidal Bukhari, medical oncologist at Military Hospital in Riyadh, with a great experience, good experience in GU oncology, and one of the leader in the GU team in the Saudi Arabia. Dr. Nidal, the floor is yours.
Excellent. You see this, guys?
Yes.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. First of all, I would like to thank Dr. Ashwaq Al-Alayan and Dr. Muhammad Al-Garni for inviting me to this great gathering. It's a very generous gesture from them, and I'm delighted to be here with you guys. I listened to Dr. Faisal, rest of the Dr. Rola's presentation, and I enjoyed it. I hope I do a good job like them, inshallah, bismillah ta'ala. Thanks to Imad, thanks to Dr. Abdul Rahim for moderating this session. وإن شاء الله يعني أكون خفيف عليكم إن شاء الله بإذن الله تعالى. طيب, these are my relevant disclosures. طيب, and this is the list of the FDA pharmacological approved agents since the mid-1990s, the year Dr. Imad was born at, 1996. And this actually slide lists the categories of pharmacological agents that was actually mentioned in the previous slide. We have chemotherapy, ARPIs or novel hormonal treatments, radioligand-based treatments, PARP inhibitors or PARP inhibitor combination in HRR positive disease. Most of those agents are life-prolonging, but not all of them are FDA approved. So we go back to TAX 327, 2004, trial that you guys all know by heart, where docetaxel showed a 3-month survival advantage in metastatic castrate-resistant prostate cancer. Cabazitaxel actually came out a few years later, and taxane and docetaxel refractory disease showed overall survival benefit in PFS. Cabazitaxel is also FDA approved in docetaxel refractory and patients who progressed on novel hormonal treatment based on CAR trial. I think this presentation will be very good for someone who's sitting for the exam. Abiraterone was FDA approved based on Cougar 301 in post-docetaxel and pre-docetaxel setting. Enzalutamide was also FDA approved in patients who progressed on docetaxel and in patients who are taxane naive. Do you, I'm sure Dr. Ahmad, do you use, have you ever used the radium-223 in your practice? Not here, yes. So this was actually investigated in Al-Simca trial that actually in patients with bone metastasis only, overall survival advantage was observed in radium-223 arm. Rolla did a great job, spoke about vision trial and showed us the benefit of lutetium PSMA 617. What about PARP inhibitors? Did anyone speak about PARP inhibitors? Rolla, I believe, did a very good job. I was stuck in traffic. But I'm going to go very quickly over Profound. Profound actually showed a clear survival advantage in cohort 8 patients. Patient group that had BRCA1, BRCA2, and a slight number of ATM. Propel tried to answer a different question. With combination add synergy and life prolongation in patients with metastatic castrate-resistant prostate cancer? The answer actually was yes. It was statistically significant only in HRR mutated patients. This was a pre-specified analysis. It is worth mentioning that only 28 or 29% of patients in Propel had HRR mutations. 11% had BRCA1 and BRCA2 in the entire population. Very acceptable side effect profile compared to other PARP combinations. This is a Propel update published in 2023. In HRR mutated patients, it was statistically significant. In BRCA, the largest magnitude of benefit was observed in the BRCA mutated subgroup. There are some observational studies that support the using of olaparib and abiraterone. Magnitude is a trial with the same concept, however, tried a different combination. It met its primary endpoint, which is progression-free survival, however, not statistically significant when it comes to overall survival. Rucaparib also met its primary endpoint, which was PFS, but no overall survival advantage. Talazoenzalutamide is another combination of a PARP inhibitor in ARPI, gained FDA approval immediately in late 2023 based on the good initial results it manifested. The benefit was observed only in HRR mutated patients, with most of the benefit demonstrated in BRCA mutated patients. Key subgroups actually benefited from this combination. Side effect profile, though, was not probably the most safe drug, I would say. Lots of grade 3 myelotoxic effects. It's a drug that I have no hands-on experience with. It's just worth mentioning. So I'm going to move on now to year 2024. Everything was prior to 2024. I think that the year 2024 was a very interesting year because it actually introduced new concepts in the management of metastatic castrate-resistant prostate cancer. I went actually for a coffee. I'm not sure if Faisal actually told you all the details about radioactive ligand treatments in taxane-naive patients, PSMA4. We spoke about it. Okay, no problem. And the combinations, what about the combinations? We spoke about it. I'm sure you did a great job, Faisal, as usual. PSMA4, this time was in taxane-naive, met its primary endpoint. Splash tried a different PSMA material. met its primary endpoint. However, most response rates were observed in the control arm. Overall survival analysis was insignificant. This is the PEACE-3 trial. I think PEACE-3, which actually Faisal did a great job talking about, tried to answer this question. Combination of ARPI and radium-223 versus ARPI. It met its primary endpoint. It showed overall survival advantage. And I'm going to move on to year 2025. Faisal, do you think it was as exciting as 2024 when it comes to practice-changing trials? Metastatic castration-resistant prostate cancer. Some people would consider it yes, but I personally believe that 2025 was not very exciting year. طبعا 2025 يعني بساعد انه الاهلي اخذ النخبه في اسيا يعني في البروستات كانسر was not as exciting. A PSMA4 survival update came out and it actually confirmed that doing lutetium-based material in taxane-naive patients instead of an NHT did not actually impact survival. You can do either way. What about NHT radioactive-based combinations? Were there any updates? Yes, there was an update for PEACE-3. The overall survival update was statistically significant based on a publication from August of last year, just a couple of months ago. As you can see, the hazard ratio is significant, statistically significant. However, the final overall analysis is still maturing. Any updates, other updates in 2025 with regards to PARP-based treatments? TALAPRO actually came out and it actually showed that patients who lack HRR mutation did not gain any survival advantage when it comes to treating with the PARP enzalutamide combination. However, HRR mutated patients have statistically significant overall survival compared to control arm. طيب. This is a subgroup analysis published تقريبا earlier this year, looking at the benefit observed among different HRR mutations. صراحة, to my knowledge, and based on looking at PROPEL and other PARP combination studies, I found out that a lot of HRR mutations that showed very minimal benefit or no benefit in other trials had some good responses to talazoparib enzalutamide combination, such as even though some of which are not statistically significant, but there were some benefit observed at least in this subgroup analysis. This is how the NCCN guidelines looked in late 2024. And this is how it looks like. It's organized in a different way. The font is different, but the content, I can tell you, remains the same compared to last year. No major practice changing trials. So how would you choose the right agent? It would be based on comorbidities and fitness, previous exposures in hormone-sensitive setting, and availability. So for metastatic castrate-resistant prostate cancer, non-HRR mutated, start with an ARPI. Those are the mainstream patients. They represent almost 90% of patients in your practice and my practice here in Saudi Arabia. I'll start with an ARPI. If not given previously, post-ARPI and fit, give docetaxel. Post-docetaxel and ARPI, Cabaz, different ARPI, radioactive-based treatment. Also keep in mind the majority of patients are not fit for chemotherapy. تقريبا 80% of my patients are not fit for chemotherapy. Consider enzalutamide radium-223 if you have access to radium. even though the combination is still not FDA approved. What about HRR positive metastatic castrate-resistant prostate cancer? The PARP ARPI combination is something I would do these days. Single agent PARP inhibitors is totally acceptable. No one blame me for doing this. Post ARPI, PARP, use a different ARPI. Consider chemotherapy, consider platinum-based treatments in patients with HRR positive disease. Radioactive-based treatment plus ENZA or radioactive-based treatment alone. Non-BRCA HRR mutated بصراحة non-BRCA لو عندي access to تلازو أو try it based on the subgroup analysis that was there or olaparib based combinations is totally acceptable. With this, I would like to conclude and thank you very much for attending this session.
Thank you all. Nidal, Faisal, you may come here. Rula, online. I would like first to start by statement to Nidal, and then we move to questions. In your presentation, in the first slide, you highlighted that I was in the era of 90s. So, to tell you the truth, غيرنا العداد ل 2000 وما بعد. لأنه اتضح في الثمانينات والسبعينات they share the same type. Present in the closed environments, using paracetamol and smell like Vicks. But what happens to change العداد في 2000 وما بعد, they are now more outside. No, it's okay. It's just a joke. So we start by Rula. The first question to you now, if we talk about the HRR positive versus negative, and the focus is HRR positive, would you use the PARP inhibitors in the metastatic hormone sensitive or leave it to castrate resistant?
Yeah, so we saw that the Amplitude trial is a very positive trial, and it answers a very important question about the role of PARP inhibitors in the hormone sensitive setting. Now, this is also intriguing because we have, the PEACE-1 and the Addison's trial that are very positive as well for the high volume population patients. So maybe the even more challenging question is for a patient with a high volume disease, should I give them the triplet therapy or should I give them the PARP inhibitor plus the ARTA? And this is not an easy question to answer. We don't have comparative trials. We don't know. But this is a very valid option for the patients, especially with the BRCA mutation, to be honest with you. It was also positive for the patients with other HRR mutations. So yeah, still we don't have an official FDA approval, but I think the approval is going to be very soon for niraparib in the first line setting in the metastatic HSPC. So yeah, I honestly don't have an answer as of today, but this is definitely an option for patients with BRCA mutation, patients with HRR mutation. But again, the most, I think, difficult question to answer now is if this patient is fit for this protocol and for the triplet therapy, because he's very young and high volume disease. What should I give him? I don't have an answer for that.
Hey, you have a comment or?
Yeah, so I agree with Dr. Rula, and I have a question after you finishing with this. So the question that's is now for Dr. Faisal, like was mentioned by Dr. Rula, for selecting treatment in hormone sensitive, we see that majority of the patient, they get just novel treatment. But if you look to the NCCN guidelines for the PSMA or I would say for the lutetium treatment they mentioned that you have to have one novel and chemotherapy. So now with the lack of using docetaxel, does that affect, the chances for lutetium for your patients, or what do you think?
So, Abdurrahim, your question is about the metastatic hormone-sensitive prostate cancer first line, yeah?
No, castrate resistant.
Castrate resistance, if they had chemotherapy.
Yes. So now the selection of like docetaxel is less and less with time. We give, for example, maybe novel, then we give the other novel when the castrate resistant. But if you look to the lutetium indications in the NCCN guidelines, and like a few months ago, they mentioned they have to have at least one novel and maybe chemotherapy, which is a docetaxel.
Yes.
So
Right,
does that
so-
affect your selection, or you just give it to those who progressed on many, many lines?
No, actually, there are 3 trials. So the one you mentioned is a vision trial, the first one where you have to use chemotherapy and ARPI before giving lutetium PSMA. Then PSMA-4 has removed the chemotherapy. Only after ARPI you can use it, positive study again. And then PSMA addition now. In metastatic hormone-sensitive prostate cancer, you can use lutetium PSMA. So now you can use it actually in any setting. You don't have to give ARPI and chemotherapy. Unfortunately, in our hospital, we are doing this thing because the approval for us is like that. But with the new trials, you can use in any setting. If it is metastatic castrate resistant, you've already used ARPI. You straight away go to the lutetium. You don't have to go to chemotherapy. And that's why we are seeing more toxicity, and we are saying it's very toxic. I have used it actually after ARPI without giving chemotherapy, and those patients tolerated very well. I've given now this patient 6 cycles already completed, and he has achieved undetectable PSA. So very well tolerated. But since we give chemotherapy, in fact, we give 2 ARPI, 2 chemotherapy, and then we go to lutetium. And by that time, the bone marrow reserves are very low, and they get a lot of cytopenias and problems. So I think the earlier use is better actually, but you can use it in any setting because we have grade 3, phase 3 evidence for all these settings.
Dr. Ahmad, I have a question. Dr. Faisal, regarding the oligometastasis, if you, for example, you have patient with biochemical progression, negative image bone scan, CT scan, and you find like oligometastasis by PSMA, do you need, there is some false positive results of PSMA. Do you confirm by doing biopsy, how you confirm this is a metastasis?
Yes, so clinically,
because you need to do like SPRT or metastatectomy, so you will do without confirming that this is true
yes.
metastasis?
So yeah, I've shown you in the trial they have shown in some benign cases the false positive, but you will know it because if it is the draining site for the prostate cancer, if it is bone metastases, so most probably it is metastases rather than it is something benign. If it is fracture, of course, this can be. But yeah, if you are not sure, that is something where you should confirm it with the biopsy. And this is what the second study I've shown you. This is what they did. The Condor study showed, and they said the correct localization rate was 84%. So whatever was seen on the PET scan when they did biopsy, 84% were correct actually. So it's most probably it is correct when they say it's malignant, and it was seen by the 3 different independent blinded reviewers. So it's not like one person saying that. So it is quite accurate in saying that when they say this is metastases, most probably it will be. But of course, there will be a 10-15% patient where you cannot. In that case, biopsy probably is a good idea.
Yeah. Another question just regarding doing FDG and PSMA. What's the benefit? For example, in the neuroendocrine, we are doing gallium-68 bit with the FDG bit. There is a scoring to classify the aggressiveness of the disease by the positivity FDG with the gallium-68 bit. What's the benefit of adding FDG to PSMA?
Yeah, so because in one of the study they have used both. They did the gallium scan, and then to confirm the gallium scan finding, they did a PET scan. And in our hospital, actually, initially when we were doing the lutetium therapy, our nuclear physicians were doing both. They were not agreeing with one. If we do a gallium scan and it's a positive disease, they said, no, we need to do FDG also. Okay, there are certain lesions which, if gallium is missing, it will be picked up by the PET scan. So the accuracy is different, plus the half-life is different for these tracers. So this is what they're saying. But now, the new guidelines does not say to do both.
Because it will mislead me.
Exactly.
If there were one negative, one positive, which one you will take?
It's not recommended. Just gallium scan is enough. In fact, there are trials going on using both tracer in one plasma scan, FDG plus gallium in one scan. So you don't have to do two different scans in one to be more accurate. This is what they're saying.
Thank you.
Back to you.
There is a question. There is a question here from the audience.
تفضل.
Yeah. So the question is, if a patient was on phase 1 trial and then they became castration resistant at cycle 6 of docetaxel, and then we discovered that he is BRCA2 positive, what is the preferred approach? So this is a tough call, but we have multiple options actually for this patient. First of all, definitely we are not going to give him more docetaxel, that's for sure. We have multiple options. We know that we had the PROPEL trial for olaparib and abiraterone. I will not prefer it because the patient was already on olaparib, right? Sorry, was already on abiraterone. So this is not maybe my best option. We have the magnitude trial, niraparib, abiraterone, again abiraterone, so I will not use that as well. And the TelaPro with talazoparib and enzalutamide, I think that this might be a more suitable approach. And then we have also all single agent PARP inhibitors that can be used in this setting, like only olaparib alone or talazoparib alone or rucaparib alone. They are all approved in this population of patients. Thank you.
Thank you, Lola. Now, a question to Nidal. The last slide or summary you did as of 2026, where do you put the triplet? If that was on your list or not. The other thing is, do you have any explanation for that curve for enzalutamide and PARP, where in the beginning no benefit and then they tend to be positive? enzalutamide مع الراديوم. There can be overlap في الكيرف. أول شيء it was no benefit first 6 months and then tend to be negative positive.
أنا من الانيشال ريزلتس صادق يا عماد، بس من الانيشال ريزلتس you want to go back to the triplet first. Where do you position triplet? Triplet, I would do it in metastatic hormone sensitive prostate cancer in someone who's fit with high volume disease, and I would use darolutamide docetaxel based treatment. It is safer than abiraterone docetaxel, and I'm building experience with it. هذا شيء. الشيء الثاني, I will save the testing for HRR when the patient becomes metastatic castrate resistant prostate cancer, because the FDA approval for niraparib and abiraterone is still pending, and I do not have access to niraparib. The other question is ENZA and radium 223. أنا بصراحة من أول publication في 2024 كان PFS positive. Overall survival, signs of overall survival benefit. Results, second interim analysis showed the consistency of statistically significant hazard ratio in favor of the combination. And still, the combination is still FDA approved. Probably need another year or two to see mature results. بس أنا عن نفسي أنا أعتقد إنه I was impressed by the results right from the beginning.
Back to you, Abdurrahim. Last question, and then you can close.
Yeah, similar to Dr. Nidal, مساك الله بالخير. So now we see with our prostate cancer, they still have good functional status and they might progress in many lines. Dr. Nidal, we know that apalutamide, like outside the NCCN guidelines, has no role in the castrate resistant. But if someone progressed on multiple lines and it's available, Is it because we did not test it in castrate-resistant, we're not using it? Or is it not an option because of similarity to other oral agent?
بصراحة يعني the only role for darolutamide in castrate-resistant disease is in the non-metastatic castrate-resistant disease, as you know very well. But there are no actually trials or good evidence supporting its use in third-line setting. It is still a third-generation androgen receptor signaling pathway inhibitors, as you know very well. And I think that if the patient progressed on enzalutamide, then I don't think that there is room for darolutamide in those people. بصراحة يعني.
I think Rahim, you are right actually, because it is not tested. That is the reason. If you see the NCCN guidelines, the triplet therapy, the only trials we have is with abiraterone and darolutamide. But the NCCN is recommending if you don't have those, you can use the others, apalutamide and enzalutamide also as a triplet therapy. Although enzalutamide in ENZAMET study has shown to be negative when you use triplet, but still they are recommending it that you can use it. So you're right actually, because they haven't used it in this setting, so that's why we don't have any evidence.
Thank you. Back to you, Ahmed.
So,
back
that's
to
it.
Dr. Ashwaq.
Thank you all for this nice presentation, and thank you for our speaker, moderator, virtual, and also thank you for the audience. We have more than 1,000 audience virtually. So now we have dinner in the ground floor, and tomorrow, inshallah, we'll resume at 9 a.m. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for attending this day, and we hope to see you tomorrow, inshallah, on the second day. We will be starting at 9 a.m. Also, we'll be sending email to those who are willing to come and attend physically. So please check your inbox. We'll send you the location and the timing. So you will be free to come, and it's free registration as well to come here physically for physicians. And we'll be happy to see you as well virtually and physically. السلام عليكم ورحمة الله وبركاته. نشكركم على حضوركم الطيب واستجابتكم لتعبئة الاستبيانات المتكررة. نود إعلامكم بأن يوم غد سيبدأ الساعة 9 صباحا، ونود رؤيتكم جميعا، ونرجو لكم يوما علميا ممتعا ومفيدا. شكرا جزيلا، نراكم غدا الساعة 9 صباحا، والسلام عليكم ورحمة الله وبركاته.